بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام مساكم بكل خير وكل عام وأنتم بخير. Good evening, good afternoon, or even good morning. Okay, dear colleagues, welcome to the fourth Riyadh Dermatology Forum. This year it happens with unprecedented situation. It happens while we have the COVID-19. Hopefully everyone is safe, healthy, and his family as well. This meeting happens where the scientific knowledge meets the clinical situation and the clinical cases. So we have the clinical lectures and then the clinical cases as well. We are very proud at this meeting. We received more than 50 cases from more than 5 countries. And all the cases were excellent, very challenging, and it makes the scientific committee in dilemma in the scoring. Everyone is interested to present the case. Everyone is interested to attend this meeting. So thank you for everyone. Thank you for you, all the audience, all the dermatologists, all the technical team, and as well as I would like to thank the Saudi Society of Dermatology and Dermatological Surgery for hosting such meeting. The Riyadh Dermatology Forum is planned to be hosted twice a year. So the next one hopefully will be in the Q1 of 2021. And we hope, inshallah, the next meeting will be face-to-face instead of Zoom. At the end, I would like to thank everyone and a special thank to you, your audience, who are spending 2 hours for the scientific knowledge and meeting. And now I would like to introduce Professor Jeneline Smith. Professor Jeneline Smith, she is the director of the Oncodermatology program at the University of California, Irvine. She is very well known in oral pathology as well as in skin cancer. So Professor Jeneline Smith, she's going to talk about the tongue and the oral cavity disorders from the dermatology perspective. Jeneline, the floor is yours.
Hello, can you hear me?
Yes, we do.
Yes, good. So greetings, everybody from Southern California. It's morning here, and I'm very, very proud to have been invited to speak with you this morning. I am going to talk to you predominantly about the tongue, but I'm going to try to relate it a bit to the oral cavity in general. So first of all, very basic, but I wanted to remind you that the tongue is a muscular organ covered by a mucous membrane, and there are 4 types of papillae. And the reason the papillae are important, you will see as we go along today. So the 4 types are the filiform papillae, which form this white carpet over the back of the tongue, the fungiform papillae, which are the red dots that you see here. This is a very healthy tongue. There's a little bit of a hemangioma here, but otherwise the filiform papillae look very nice, very dekeratinized. If you look at this picture, this is somebody with a less healthy tongue. They have not got a good diet. They do not have good oral hygiene, and the filiform papillae become very hyperkeratotic and very yellowed. There are 2 other types of papillae, the circumvallate papillae, that's one here. They have a little moat around them that are filled with lots of taste buds, and they also contain the glands of von Ebner. The glands of von Ebner secrete lipoprotein lipase, and when a baby suckles, the milk falls over here and is pre-digested before it gets to the stomach. These will show up in your clinic because people will read about HPV in the oral cavity and they will think that these are warts. So be familiar with what these look like. These are not warts. The 4th type of papillae are the foliate papillae. They're here along the lateral border of the tongue, and there are many folds and many, many, many taste buds. The time you will see foliate papillae in your clinic are when they are bitten. So they are very painful because they've been bitten, and they take on this very characteristic pill-like shape. There is often a little pocket of pus at the base. People, again, think that they have cancer on their tongue, and they do not. Unfortunately, cancer is rarely painful, so the pain is your first clue, but also this characteristic shape. Give them a soft diet, have them back in a couple weeks, and it will be gone. One of the normal variations that we see on the tongue is called the fissured tongue, also known as the scrotal or plicated tongue. It often has a deep crevice down the middle and many secondary fissures along the sides. It has an incidence about 5 to 7%, is usually asymptomatic, but occasionally what we'll see is somebody gets a piece of food caught in it, and then it gets painful. It can be associated with certain conditions, most notably Milkerson-Rosenthal, psoriasis, and Down syndrome. Here is a very characteristic fissured tongue. Here is another. I think you can see here how you might get something caught down in here, and you just need to dislodge it with a soft toothbrush of some sort. If somebody comes in and they look like this and they have a fissured tongue, obviously you're thinking something else. So you look for other clues to make sure the fissured tongue is not associated with something else. This is Milkerson-Rosenthal. Now, there have been some recent studies that suggest that maybe there's more to fissured tongue than we realize. And the most common thing we see is something where they're looking at something like psoriasis, they give them a biologic, their fissured tongue gets better. So I think there's more to this story that will be coming out in the not too distant future. Crenations, these are the indentations that you see along the tongue from pressure against the teeth. These are normal variations when they're seen like this. If they have ragged teeth, they often have ragged crenations as well. And the time when we worry about them is when they start to creep up onto the back of the tongue, the dorsum of the tongue. This suggests that the tongue is getting larger, developing macroglossia. And this patient in particular had amyloidosis. So you watch for those to creep up onto the top. Here is another one. They are often a little bit ragged because they're not used to having a large tongue. This again, amyloidosis. So watch for that feature. Physiologic pigmentation. So it's common throughout the oral cavity, but it's actually uncommon on the tongue. When it does occur on the tongue, it often involves the fungiform papillae. So you can see that here. The fungiform papillae, although we think of them as being scattered across the dorsum, they're actually concentrated on the tip and the lateral part of the tongue. If you use mucoscopy, that's what we call dermoscopy when we use it on the mucous membranes, you can see again, these are the fungiform papillae. They're very vascular. The filiform papillae over here. This is the fungiform papillae that are involved. If in doubt, look throughout the oral cavity. This is a very typical feature of physiologic pigmentation. Here's a little fellow that has it as well. Caviar tongue. This is phlebectasias due to loss of vascular wall elasticity. It's most common here along the tongue or on the ventral surface. We've always said that it's unrelated.
I think the slide is not moving. We just kept on the amyloidosis picture. Can you just make sure that yeah.
Okay. Shall I go back? Previous. Are you seeing it move now?
Still no. Can you just maybe share and share your screen again?
Okay, a good idea. Stop share. And okay, now I'm going to move again. Is it moving now?
Still, we don't see your screen. Just maybe take a few seconds. We just started.
Are you seeing the amyloidosis?
No, we don't see any slide.
Oh, shoot. Okay, we'll call in the troops here. Let's see, what else could I do? Let me stop sharing again.
You can share again your screen meanwhile.
Yeah.
Maybe sometimes.
I'll try this.
As I started screen sharing.
Are you seeing it move now?
No, still we don't see any slide.
So you're not actually seeing, or it's just not moving?
We're not seeing any slide anymore. Okay, we're seeing
dear.
only blank one.
Okay, so they're not seeing my slides, Daddy.
How far did you get into the talk?
Quite just to here, but so they saw up to amyloidosis and then they stopped seeing.
Okay.
So the stop share,
Yeah,
share screen.
Yeah.
I've done it. Come back.
Okay.
Share.
sure no one's using the internet upstairs.
Let's see. So seeing anything yet?
No, still it is blank one.
Hmm,
You just started screen sharing.
okay. So nothing. Okay, we're working on it from a different angle out here.
Sometimes this is the sometimes of technical things.
Yeah,
It's always
sorry about
happening.
that.
Okay, it's always happening. So that will be
Yeah.
fine. So,
So they're not seeing anything. They're seeing a blank slide.
That's no good. So why don't we, you could always reboot.
The whole thing?
You want to give us 5 minutes and we'll try and reboot?
That's kind of a long time. Let's see.
yeah, okay, let's see. Okay. So again, welcome everyone to the fourth Riyadh Dermatology Forum. And this time we received more than 50 cases. Okay, and we have many participants from outside Saudi, from different countries.
I'll do it.
Okay, from Indonesia, from UK, from Tunisia, from Egypt, United Arab Emirates,
Yeah, they can't see
from
this.
different countries. So this is okay.
Oh, wait, I need to, oh, sorry, guys. We need to turn it off.
Okay, you can just take your time. We will be managing.
I'm so sorry. I'm so sorry.
That's okay. It's always happening. Okay. So this time with these, we have chosen the top 11 cases, and at the end of the meeting, you will be able to vote for the top 3 cases. For these 3 top cases, we will divide the voting into 2 parts. For the first 5 cases, you will choose the best 3, and then you're gonna choose the best 3 from 6 cases, and then the final will be between these. The chosen 5 cases will be the top 3. The winner for the first place and second place and third place, they will be appreciated and rewarded at the end of the meeting as well.
Dr. Yusuf, in case that her slides doesn't work, there's an
So welcome everyone. I'm sorry for this technical issue, but we will be solved inshallah within a few minutes, or if not a few seconds. Again, this dermatology forum is a platform to meet with mainly the clinical knowledge as well as the clinical science. So for any challenging cases, interesting cases, please submit it for the next meeting. We know that some people, they argue that they have been sending a few cases this year and last time as well, but they haven't been chosen. The competition is very high. The cases are very interesting. So we are in very tight angle as scientific committee to choose the best 10 or 11 cases because the time is very tight and short. However, we are encouraging everyone to submit cases for the next meeting. And the next meeting, inshallah, hopefully will be in Q1, and hopefully it'll be in the physical face-to-face. We are very happy and very proud that the contribution of the participant is not limited to one region, all over Saudi, all over the region, the Gulf countries, the Arab countries, or even the world as a whole. So if we see that an advantage of the COVID-19 is that meeting virtually to meet everyone. So from a state, from the west end, from the Pacific Ocean till the east, for the Indonesia, or maybe beyond that, everyone is meeting on Zoom or whatever platform to discuss the interesting cases. We have 11 interesting cases that are very interesting from different backgrounds with different uh, morphological aspect and from different educational points. Each case is very interesting and it's unique in its situation. So we'd like to hear your positive as well as negative. So we are not like fully so we are not without any problems. There should be some like mistakes that could be happen, but please, if you have any problem, please let us know and to correct it in the future. This meeting is from you and to you. It's not from us. It's you are the one who is managing everything. So far we with the few slides we received like 5 or 6 questions for Professor Jonathan, and Professor Smith, she will be soon with us and just fixing her slides. So would like to keep you tuned, everyone, and we'll see. Uh, the thing that in the future, inshallah, we have different opinion and different ideas about how to get the most use of these very interesting cases. So some of these interesting cases are so rare, and some of them are they do have therapeutic challenges, and some of them they do have diagnostic challenges as well. So it's very interesting to look into these. These cases are not limited to one region, so we have to discuss it. It is all globally. The beauty of dermatology is that it doesn't know any boundaries. So it doesn't know that this from the east or from the west. So, and it is very interesting. And we encourage everyone to send more cases for the future, especially in therapeutic background and with any interesting or any new innovation or therapeutic modalities. So we'd like to hear from you the negative more than the positive things. We'd like to improve. And we'd like to thank the Saudi Society of Dermatology and Dermatological Surgery for hosting such meeting. It's the fourth one. We had 3 successful sessions in the past where they were face-to-face, and this is for the first time to be done virtually. If you like the idea of the virtual, we could do in the future as well, maybe hybrid meeting where they do have face-to-face and some virtual. Though the virtual things, sometimes they do have technical issues. However, technical issues always can be solved easily, inshallah. And we are just waiting to have this one. It's very interesting that in the previous talks, in the previous Riyadh Dermatology Forum, we have been talking about connective tissue disorders, rheumatology and dermatology with Dr. Sheikh. And also we have been talking about HIV and in dermatology by Dr. I forgot the name, okay. And nowadays we are discussing the oral pathology. So we are trying to cover most aspect of dermatology from the oral pathology, from the rheumatology, psychology, as well as the HIV and other infectious disease in dermatology. So this is important thing. As long as you are giving us the ideas and with your support, everything will be inshallah successful. As we mentioned earlier, the meeting is the merging of the clinical knowledge and the clinical cases. So that what is interesting about this meeting, it doesn't only give you it doesn't deliver only a lecture. It delivers also the clinical science okay, and the management with difficult diagnoses, difficult therapeutics, and sometimes challenging cases. So it is very interesting to see different views from all of you. So we would like you to ask the questions during the any case presented. If you have any questions, please type it in the chat box. We will be more than happy to discuss your question with the presenter as well as with the audience. So hopefully you will see. So we would like to thank you for your patience. Okay, as we mentioned, this is technical issue, and we will see how things are going on. If you have any comment, please don't hesitate to send it to us on our email info@Saudi Society of Dermatology and Dermatological Surgery .edu. Please do not forget to send us. Your comment is very important. This meeting, it has 4 CME hours credited by Saudi Society, by the Saudi Commission for Health Subspecialties. So please be sure that you enter your correct Saudi license registrations number, please. So it's very interesting to see how the medical student and interns are participating in this Riyadh Dermatology Forum. We have received many participation and many cases submitted by the student, interns, and resident as well. This is very positive in that way that we are preparing our students and interns for the bright future for the scientific research and publications. So we'd like to thank these students, interns, and the resident. As well as we would like to thank you their mentors as well. So the vote at the end of the meeting, what will happen that we will ask you to vote. We will ask you to vote. We have divided the cases into the first 5 cases and then the 6 cases at the end. So you're gonna vote first for the first 5 cases for the top 3 of them, 3 out of 5. And then you're gonna vote for the top 3 out for another 6 cases. So the total you will have 3 from the first 5 and 3 from the last 6 cases. So the voted 6 cases now, you will re-vote again for the among these 6 cases for the top 3. So you will have part 1, you will vote among 5 cases, and part 2, you're gonna vote among the 6 cases. The chosen 6 cases, we will be re-vote again to choose the first place, second place, as well as the third place. In case there is like 2 cases they have the same voting number, then the prize will be divided equally between them. Okay, let's say we have like in the X case, we have 100 vote, and Y case, we have another 100. So the prize will be divided for this place into these 2 parts. And I'd like also to thank our strategic sponsor, which is Johnson & Johnson, for sponsoring this event and to also partners with the Saudi Society of Dermatology and Dermatological Surgery. So it's very important, okay, to know the voting process at the end after the second sessions, which is hosted by Dr. Mohammed Al Jasser. Then we will start the voting for the first 5 cases. The first 5 cases will be shared by Dr. Hind Shihri, and then you will vote among these 5 the best 3. And then the second session will be chaired by Dr. Mohammed Al Jasser, and you will choose the best 3 cases among these 6 cases. These chosen 6 cases, you will re-vote again to choose the best 3 cases for the first, second, and third place. If you have any question about the voting process, let me know about it. And if you have, please let us know in the future to work on it accordingly.
Hello, Yosef.
Hi, welcome
Hi,
back,
I'm
Professor
so
Smile.
sorry.
It's okay. It's always happening with technical things. Okay, we have some discussion with the audience about the voting system. The floor
Okay.
is yours. You can share your presentation.
So do you want me to share a screen again?
Yes, please.
And you could hear me up to amyloidosis, right?
Yes, that's right.
Good. Can you actually see me changing?
Yes, that's good.
Okay. Good. So you let me know when I should start again.
You can start right now.
Oh, okay, good. So I think we made it to amyloidosis, and then we're going to talk about the physiologic pigmentation. Now, you didn't see those slides, is that correct?
Correct, yes.
Okay, so with physiologic pigmentation, also known as ethnic pigmentation, the tongue is rarely involved. It's very common throughout the oral cavity, but not the tongue. And when it does involve the tongue, it involves the fungiform papillae. So you can see here a nice distribution of the fungiform papillae with this physiologic pigmentation. When you use mucoscopy, which is our form of dermoscopy in the mouth, you can see also here are the fungiform papillae, which are the very vascular papillae here, as contrasted to the filiform papillae over here, it is the fungiform papillae that are involved. If in doubt, look through the rest of the oral cavity. This is a very characteristic form of physiologic pigmentation. And here we have a little guy with similar pigmentation. Caviar tongue. This is phlebectasia due to the loss of vascular wall elasticity with age. So you see these dilated vessels here, and the other most common site is the ventral surface or underneath the tongue. It has often been said that it is unrelated to systemic disease, but there actually have been a couple of papers that suggest that maybe it has some relationship to smoking and cardiovascular disease. So this is what caviar tongue looks like, little bits of caviar here. And just like caviar in the real world, it comes in many different colors these days. So don't be disturbed by the fact that they're in here. Here we also have caviar tongue. Configurational distortions. So in the United States, 2/3 of the population can roll their tongue like this, 1/3 cannot. This is called a reverse roll, and a reverse roll is extremely rare. And in fact, if anybody listening today can do this, I would love a picture of somebody doing a reverse roll, because this one's very old. This is actually called a dorsal tip fold. A dorsal tip fold can be done with the teeth fairly easily, but to do it without the teeth is actually uncommon. This one is called a trefoil tongue, also known as a clover leaf tongue. Developmental anomalies. You can actually be born with a small tongue, and the main complaint there is that it's hard to lick ice cream. You can also be born without a tongue. This is a young man who presented to a dentist, and he had total absence of the intrinsic tongue muscles. The mucosal lining was intact, the taste sensation was intact, and in fact, he actually spoke reasonably competently. Of him, and you can see the mucosal surface here that is not met in the middle over those muscles. This is another patient who actually learned to billow out the floor of his mouth to simulate a tongue, also born without one. Macroglossia. This is an isolated anomaly, is extremely rare. So when you see somebody with a large tongue, it's almost always because there's an underlying tumor or there's an underlying disease. There is something called relative macroglossia, where somebody actually has a normal sized tongue and a small mouth. That's seen most commonly in Down syndrome. Here's somebody with a very large tongue. You would say that is definitely macroglossia, and what he has underlying this is a lipoma. Here's another lipoma, a little bit more characteristic with the yellow. And here's another one, and here it is coming out. So it looks just like a lipoma in any other site. Choristomas, these are ectopic tissue, that is normal tissue in an abnormal location. There are multiple lingual subtypes, bony, cartilaginous, etc., but by far the most common is the thyroid choristoma. This is a young baby who was born with a piece of brain on the back of the tongue. Here is another patient. This is also a tiny little piece of brain. This is an osseous choristoma, so this is just bone, a little fragment of bone on the back of the tongue. And again, the most common is the thyroid choristoma. Embryologically, the thyroid starts on the base of the tongue and works its way down into its normal pre-tracheal position. It can actually even go further and be found in the mediastinum sometime. But when we see it in the oral cavity, this is what we usually see. This is not something you want to biopsy. Here's another one. And the reason you don't want to biopsy is that 70 to 75% of these patients, it's the only thyroid tissue present. So what you want to do is scan it. If it's the only tissue present, you can work with your ENT colleagues, and they can sometimes transplant it into the pretracheal area. Genetic syndromes. Now, these are really important for dermatology because we can sometimes change people's lives by recognizing some of these. Now, this is what everybody probably knows, hereditary hemorrhagic telangiectasia, also known as Osler-Weber Rondeau. These patients have multiple vascular papules, often anywhere, actually often on the tongue and anywhere in the oral cavity, and they come in many different distributions. Here is somebody with some telangiectasia on the inner lip. They can also be found elsewhere on the body, and the two most common spots are actually on the tips of the fingers and on the ear. So I've made the diagnosis once by noticing this on a man's ear. This is autosomal dominant, but spontaneous mutations are rare. And the importance of that is that you almost never see somebody who doesn't have somebody else in the family with this. So you need to take a good family history as well. The prevalence is about 1 in 10,000, and the most common place to find it is actually in the Netherlands Antilles, just north of South America. It has a wide ethnic geographic distribution. Age-related penetrance is also important. So what that means is that if you see a child from a family with HHT and he's 5 years old and he doesn't have any of the things, that doesn't mean you don't have to watch him. With time, some of these things will come out. So what we see is about 95% of these patients have epistaxis, that is nosebleeds, 95% telangiectasias. And importantly, these don't actually happen till well after the epistaxis starts. So if you have somebody with epistaxis, finding those telangiectasias, keep an eye on them. The other characteristic finding is the arteriovenous malformations. The ones in the brain are most often congenital, and the liver and lung develop over time. And again, developing over time, we're watching these patients, we're watching these families very carefully. Here is a patient with a pulmonary arteriovenous malformation and the efferent and afferent vessels that go to them. This is a lady who I followed at the University of Minnesota for quite some time. She actually had an AVM of her external auditory canal, and as she got more and more pregnant, the ear got larger and larger. So when she got to the point where we could do a C-section. Of note, if you have a woman who's going to be pregnant, it is a good idea to actually do an MRI of her spine, because if she has an AVM of the spine, the anesthesiologists, actually, if she doesn't have an MRI to show whether she has one, the anesthesiologist will not give her an epidural and she won't be very happy with you. The fantastic website, hht.org. If you want to follow these patients, it gives you a stepwise thing to follow. If you do not want to follow them, it tells you internationally who will follow them for you. Hereditary angioedema. This is a non-allergic form of angioedema. It's mediated by bradykinin, not by histamine. So these patients have poor response to antihistamines, corticosteroids, and epinephrine. There are a number of different modalities to treat with them with these days. So if you have a patient with this, please familiarize yourself with these. This is a non-pitting, non-itchy swelling of the face, extremities, and abdomen. It may also include the mucosa of the GI, GU, or respiratory tract. These patients often present to an emergency room with belly pain, but they can also have these swellings that we can diagnose. There's also a characteristic lacy erythema that they develop. It's referred to as erythema marginatum, not to be confused with the other erythema marginatum, but as you can see, it's a fairly characteristic presentation. They also can develop saxophone penis. So this is what it looks like. I don't think I have to tell you why they call it a saxophone, but they get intermittent swelling of the genital area. I've actually made this diagnosis twice, although it isn't exactly hereditary. The one that I diagnosed, the two that I diagnosed were both ACE inhibitor associated angioedema. So very, very similar pattern of symptoms in patients taking ACE inhibitors. It occurs in 0.1 to 6% of the US population. I don't have any figures for Saudi Arabia. Blacks more than whites, women more than men, and smokers more than non-smokers. So this is a typical presentation. So they get a swelling. It's pretty characteristic. Here's another guy, actually more severe case. And as you can see, there is swelling of the GI as well. So this patient had significant GI distress. So in the US, 25 to 38% of all emergency room visits with angioedema are actually this. So we always have to keep this in mind. When asked, alternate ACE inhibitors are contraindicated, and there is some question as to whether ARB should be used as well. So probably some different type of hypertensive medication should be used. There are a few other medications where we have a question as to whether they might also be setting this off. It's unclear whether they can set them off on their own or whether there always associated with an ACE inhibitor, but there are some here that are actually, oopsie, go back again. There are some here that are actually quite common, the gliptins in particular, so be on the lookout for this sort of thing. MEN2B. This is multiple endocrine neoplasia 2B. They develop medullary thyroid carcinoma and pheochromocytomas. And again, dermatologists can be the first people to recognize this because they have very characteristic multiple mucosal neuromas, which present as multinodular tongue and blubbery lips. So a patient who has some nodules, usually peripherally on the tongue, and then a very large lip. Here is a characteristic look to the lips. Again, they tend to be more peripheral, and this will be important later when we're looking at a different syndrome, but they have the peripheral papules and nodules. If in doubt, there's a pathognomonic feature that you see on slit lamp exam, which involves the corneal nerves, which are quite thickened. This is 50% autosomal dominant, 50% sporadic. In this case, you may not find somebody else in the family that has the disorder, so it have to keep a high index of suspicion. Again, they have an aggressive form of medullary thyroid carcinoma in 90% of the patients. The average age of death is 21 with metastases prior to the age of 10. It is recommended that they get a prophylactic thyroidectomy before the age of 4, and in fact, the American Thyroid Association has now said before the age of 1. So this man you may or may not recognize, but he was president of the United States back in the 1860s. This is Abraham Lincoln. He was well known to have a Marfanoid habitus, and it was thought to have Marfan syndrome. Some people have suggested that, in fact, he actually had MEN2B. In many of the pictures, he looks to have a blubbery lip. Another thing that he had was a very significant constipation. That's a very characteristic feature of this disease as well. He also had many people in his family that died at a young age. It was thought to be consumption, but back in that time, they had little way of knowing what was going on if it was this disease. And apparently his mother was quite typically Marfanoid as well. So here we have another tongue with lots of papules. Again, not the more peripheral pattern, but more diffuse. Cowden syndrome, another syndrome that you can pick up. It isn't always as obvious as the first slide here, often little papules like this. And sometimes when there are a lot of the papules, a fissured tongue. So make sure when you're looking at your fissured tongues, you're looking for papularity as well. They also will have oral papillomatosis, lots of little papules throughout the oral cavity. This one is autosomal dominant as a germline mutation with the P10 gene. The important thing for us is that the cutaneous disease precedes the systemic malignancies. So we can pick up on this. We can change this person's life by diagnosing these cancers early. Pachyonychia congenita, here's the characteristic features we see in the nails with the thickening. They often have a palmar-plantar keratoderma as well, often this linear form. Here it is on the feet, and you might say, well, why are we looking at this in a oral cavity lecture? Well, the third characteristic is something called leukokeratosis of the mucous membranes, and they often get this very diffuse hyperkeratinized filiform papillae. These mucosal changes are without malignant potential, thank goodness. When we used to talk, we used to say PC1 and PC2 of note. Nowadays, they say PC and whatever the keratin mutation is. So PC K6A, PC K17, and if it's unknown, it's PCU. So we have this very even hyperkeratosis that you see here. Here we go, leukokeratosis of the mucous membrane. In children, it can be a little bit more spotty like this. Eventually, they develop the more even hyperkeratosis. If you see this in an adult, so this is an adult with patchy hyperkeratosis, this is not pachyonychia congenita, this is dyskeratosis congenita. So be careful not to make this distinction. Sometimes they'll actually look a little lichen planus-like, so you can see there's some almost Wickham stria-like look here. They have a squamous cell carcinoma here, which is very characteristic of the patients with dyskeratosis congenita. Here is a man that presented to these people with this keratosis congenita, got lost to follow-up, and came back with a very large squamous cell carcinoma on the tongue, so characteristic of this disease. The skin findings are interesting. I think that you can see that this is sort of a unique hypomelanosis diffusely. Even over the palms of the hands, we can see it here. And hard to think of anything else you would think for this, maybe hypopigmented MF, but this is a pretty characteristic finding in these patients. The third part of the triad is loss of the nail, them losing the finger. So the classic triad again is the reticulated skin pigmentation, nail dystrophy, and this leukokeratosis of the tongue. They have a high risk of bone marrow failure in 80 to 90% of patients by the age of 30, and it is the leading cause of death. So again, squamous cells of the tongue, AML, myelodysplastic syndrome, we can make this diagnosis and we can help to help these patients and make these diagnoses early. Recently, there was a paper that looked at families of people with this keratosis congenita, and they found that only 37% of those who actually had the gene defect had the full triad. So don't let somebody without all three make you think that they don't have it. Infectious disease. So when you see an abscess of the tongue, it is almost never an acute abscess. For some reason, this tongue is very immune to this. It happens at the nadir of somebody's chemotherapy, but otherwise not. If you do see an abscess of the tongue, it tends to be this. It is a slow growing indolent abscess, and it is caused by this guy here. And this is actinomyces israeli. These need to be drained and sometimes require antibiotics. Bacteria can affect the tongue, of course, but most often in a toxin-mediated way. So this is an early stage strawberry tongue. We call it a white strawberry tongue. That's because you can see here the filiform papillae aren't dekeratinized, and here they are. So this is a strawberry tongue. Viral. Primary herpetic gingivostomatitis can affect any portion of the oral cavity. The tongue is not immune. Here we have a very painful tongue and also more of the oral cavity involved. Here you can see, actually I like this slide because it has a very sweet little bunny rabbit here in the middle, but you can see this patient is in pain. They're not eating well. They're not dekeratinizing their filiform papillae. They can move on to a more mucositis-like picture with ulceration, and it looks like this. And in fact, it can get quite dramatic over time. If you see recurrent herpes simplex of the oral cavity, it tends to be subtle and it tends to be above the lateral border of the tongue. So viral tends to be above the lateral border, aphthous tends to be below. So you see this is not aphthous, this is recurrent HSV. In immunocompromised patients, you can actually see this configuration. It has a very geometric look to it. This is called, in fact, herpetic geometric glossitis. These patients often come to you with a burning tongue, and if you can recognize this pattern, they're very grateful because it is very amenable to oral antivirals. You can see an ulcerative form of HSV on the tongue, but it is almost always in severely immunocompromised patients. Varicella zoster, just like anywhere else in the body, it's actually pretty easy to pick up. So you tend to have two very different aspects of your tongue. It occurs due to either involvement of the chorda tympani branch of the facial nerve or the mandibular branch of the trigeminal nerve. Here, lots of mucositis going over here and not much over here. It is sometimes referred to as chocolate and vanilla tongue. I think most often I've seen it as been more strawberry and vanilla tongue. This is called median rhomboid glossitis. This is actually an oral Candida infection. So this is loss of the filiform papillae and Candida here. It is most often asymptomatic, and actually for a long time there was some question as to whether it was a primary candidal infection, but most people feel that it is at this point. Sometimes it's not quite as rhomboidal, sometimes more triangular, I guess you'd say. Here is somebody with one that's quite large. Note here that these are one single lesion. No matter how large they are, they're one single lesion. And that's important when we talk about syphilis later, because you can get a similar look with syphilis, but it's a more patchy look. Here's another person with a large lesion. There is something also we call KIT, is candidal inflammation of the tongue and nonspecific inflammation of the palate. Also back in the day called the AIDS thumbprint. And what it means is that in immunocompromised patients, sometimes you'll see the median rhomboid glossitis. And when you tip them up and look at their palate, you see a corresponding erythema. This is a sign of immunocompromise. And if they don't already have that diagnosis, you need to look into it. When you see nodules and ulcerations of the tongue, it is almost always some sort of infection. So this is a patient of ours who had pemphigus, was on high-dose steroids and other immunosuppressants, and developed coccidioidomycosis, which is common in our area. Here's another patient, large nodular areas, lots of mucositis here, probably some erosion underneath. This patient actually has tuberculosis. So pretty characteristic when you see these. Syphilis, you can get a chancre of the tongue, you can get a chancre of the lips. So it has been described, can't say that I've ever seen one myself. So usually what I see is more the secondary syphilis. These are characterized by mucus patches, which when on the tip of the tongue look like this. When you're more dorsal on the tongue, they tend to be a little bit more atrophic. So you get atrophic filiform papillae, and again, not like median rhomboid glossitis. This is multifocal. Here we have it again. Sometimes they're a little bit juicier. And here we go again, more juicy secondary syphilis lesions. Benign neoplasms. We're not going to dive deeply into these, but what I will tell you is two things. One is when you see it on the tongue, it often looks much like it does on the cutaneous surface, and we'll see a few examples of that. The other thing is that the one thing that has not been described on the tongue is a nevus. So if anybody finds a nevus on the tongue, you and I can write it up because it has never before been described. So here we have a pyogenic granuloma, and again, a little bit different than you see on the cutaneous surface, but it even has a little cuff like you often see there. This is an angiokeratoma. Again, I don't think you would probably miss something like that. Mucoceles are unique to the oral cavity, but this is just a transected salivary duct and pretty typical look. Sometimes you will see that they bleed into them. Don't worry about that. That's actually not an unusual thing to see. Malignant tumors. We're going to talk mostly about squamous cell today. There are distinct groups of patients that we see with squamous cell. The most common group we see is the alcohol tobacco-related tumors, but we also see HPV-associated tumors. And then there's a third group that has many, many different names and is probably very heterogeneous, but this group has referred to it as the non-drinker, non-smoker, HPV-negative group. We're going to talk about these first two today. So alcohol tobacco-related tumors, the male to female ratio is 3:1. The average age is in the 7th decade. The tumors occur in the saliving pooling areas. With the tongue, it's the lateral and ventral surface of the tongue, but the other place is floor of mouth, where we see this not infrequently. We in the United States have a decreased incidence due to the decline in smoking. I did look up some numbers for Saudi Arabia. It appears that you have some areas that actually have quite a bit of the alcohol tobacco related tumors still because of your incidence of smoking and chewing of tobacco. HB positive tumors show similar, but at a much earlier age. They also tend to have a higher socioeconomic status, higher education, and an increased number of lifetime sexual partners, especially oral sex partners. These tumors have a preference for the lymphoepithelium of the oropharynx, so base of tongue, tonsils, that sort of area, and what we would think of as Waldeyer's ring. So in fact, these two entities have become so distinct in the literature that WHO actually updated their classification of the oral cavity. Now, when we talk about the oral cavity, we're talking back to the end of the hard palate, and beyond that is the oropharynx. So tobacco, alcohol-related tumors tend to occur here, HPV-induced tumors here. Here we have a pretty characteristic tumor that is tobacco alcohol related. You're not going to see the tumors of the HPV variety. You might see, so again, much further back in the oral cavity, actually behind the oral cavity at this point. I have made the diagnosis twice based on nodules in the neck, so keep a high index of suspicion if somebody comes up with a nodule in the lymph area of the neck. I am by trade a melanoma doctor, so I just had to show you that it does occur on the tongue, but it is extremely rare. So this is a melanoma of the tongue. When it does occur in the oral cavity, it actually is most common on the palate. So this would be a characteristic look of a melanoma in the oral cavity, or on the mandibular alveolar ridge in this area here. Metastatic tumors do occur in the oral cavity. This is actually a renal cell, which I thought was very interesting. I'm always telling the residents renal cells, even when they're in the cutaneous surface, often have this sort of cherry look to them. You're all familiar with pemphigus, so we won't talk too much about that, but I do want to point out the fact that these people are in pain. And I think you can see this here. They're really not dekeratinizing very well. This has been here a long time. It's got discolored. You can see bullae in the mouth. They tend to be along the lateral border, but oftentimes they become erosions very quickly. Here's another patient also not eating very well, and here is a bulla. Oral lichen planus, a talk on its own, but let me just say that there are multiple different presentations, the most common being the reticular form that you see here, ulcerative form as well. Oftentimes you will see them mixed as you do in this patient here. This is a plaque type of oral lichen planus, and again, a mixed picture with ulceration as well. This was an interesting case. This is a lady came in for slightly painful, although not terribly painful, bright red erythema of her oral mucosa. So she had that, and then she had this on her tongue. And you might say, sorry about that, you might like lichen planus, and it does. But again, look at this erythema, this very bright red erythema that you see, and it's streaking in places. This is actually a patient with systemic lupus erythematosus. So when you're thinking lichen planus, make sure that you're also ruling out those SLE patients. When you look elsewhere in the oral cavity, they will have actually what are probably typical discoid lesions. So which tends to be much more diffuse here, they will have a very well demarcated area here. And again, that bright red cherry look to it. As we spoke earlier about nodules in the oral cavity, and yes, indeed, it's most often infectious, but occasionally you'll see this. This is a patient with sarcoid. So nodules can also be sarcoid in the right circumstances. This is one of our residents. She came to me one day and she said, Dr. Smith, why is my tongue turning a funny color? And we all felt very badly because we had been giving her a really hard time about her beautiful tan that she had, and told her that she couldn't have a tan anymore now that she was a dermatologist. But in the end, she was diagnosed with Addison's disease, and we all felt very badly. This is another patient with Addison's disease. They can get some accentuation of their fungiform papillae, so don't let that fool you, but they often have this just much more diffuse hyperpigmentation in the background. There are things that we do to patients that cause them to have hyperpigmentation as well, so don't forget there are some drugs that can cause it. This is a patient who was on pegylated interferon. This is something you've probably all seen. This is a patient with minocycline. Again, you can get accentuation with those fungiform papillae, but you also see diffusely over the back that they have this. This is the other time that we tend to see it, and this is with heart. And last but not least, what do patients do to themselves? I suspect you don't have as much trouble as we do in the United States, though we're seeing less of this. What we found is that these patients tend to chip their teeth a lot, and so these don't last very long. They're unhappy that they're chipping their teeth. This is a young man who fell asleep in one of the phototherapy beds and burnt his tongue. So I guess that's a self-induced thing as well. And unfortunately, in Southern California, many people are very concerned about what they look like. And so one thing that's been being done lately is some of the plastic surgeons are tying these mesh pieces onto the tongue. This is to make eating painful, and so the patient loses weight. They're calling them tongue patches. So that's sort of the end of it. It was kind of a whirlwind tour there, but that is the tongue in a nutshell. Oh, you're muted, Yosef. There you go.
Thank you, Professor Smith, for this very interesting overview of the oral pathology. Actually, we received like many questions, but because of the time, I will ask you only 2 questions. The
Oh, ask
first
me as
question.
many. I feel badly that I've had such trouble, so please ask me as many as you.
Thank you, because we have a full program.
Yes.
Okay, so we will. The first question: what are the oral manifestations of COVID-19?
Oh, good question. That is, well, honestly, I've not been called in on one yet. You know, we do have, actually, that's not true. We have had a few patients we've been called in for oral candidiasis, so that's there. And as you probably realize, oral candidiasis is not just thrush. So one of the things that's been a bit difficult for us is that the erythematous variety, which just shows you a bright, can also be drug related and that sort of thing. So we've had a little bit of trouble with that, but that's the main thing that I've seen. Not really anything else at this point.
Okay, thank you. The next question is that what are the red flags in the oral pathology that as general dermatologists have to be aware whenever he sees these red flags, he has either to refer to one who has like more interest in oral pathology or to the maxillofacial surgeon?
I think the one thing that is important is to familiarize yourself, and I didn't show many pictures of this, but familiarize yourself with what early precancerous things look like. So for example, there are a lot of things that almost look a little bit like lichen planus, but they are not. They are precancerous areas within the oral mucosa. One thing to keep in mind is if you see areas that are very, so you see a white patch, a leukoplakic patch, and it's very well demarcated, that's supposed to be a key feature of precancerous disease. The other thing I would say is that everybody's a little bit afraid to do biopsies in the oral cavity, but with those sorts of patients, if you're thinking precancerous, I actually do a couple of biopsies. Because you can do one little area and find only a little bit of dysplasia, but another area might show you more extreme dysplasia. So I would not hesitate to do multiple biopsies there. The other question that comes up, just since we're talking about biopsies, is how to biopsy the tongue. And I will tell you that the only time that I've ever gotten into trouble, and this is actually way, way back, was when I tried to biopsy the base of the tongue. So the base of the tongue is kind of like a sponge with lots of sort of open areas in it. So if you biopsy and they bleed into it, they can actually get swelling of the tongue and compromise of their airway. So anybody, I will biopsy the anterior 1/3 of the tongue, but I'm really hesitant the further I go back on the tongue. The other thing to remember is that it is a muscle. So because it's a muscle, it can pull out the sutures very easily. So the saying that they have in ear, nose, and throat is twice as many, twice as deep. So when you're putting in your sutures, it's not the same as putting in a suture in somebody's arm. You put in those sutures deeper and you put in twice as many as you would have otherwise.
Okay, good. Thank you. Thank you, Professor Smith, for this very interesting lecture and overview about the oral pathology. Actually, we reached the capacity of the Zoom. We have 3,000 audience, and
oh my goodness,
we have more than this, and have been directed to go to our channel on the YouTube. So thank you, Professor Smith, for this very interesting overview.
And I apologize for all the computer problems, but I loved doing this, and I'm happy to answer anybody's questions online as well. Take care.
Thank you. Thank you for your time. Thank you.
Thank you.
Thank you. And now we're going to move for the second part, and Dr. Hind Shihri, she will share the next part. Thank you.
Good evening, everyone. Good evening, everyone. You hear me? Okay. Good evening, everyone. I want to welcome you again for the second session. Sorry for the delay in the meeting schedule. First, we would like to thank all the participants for all the exciting cases we received. And sharing these interesting cases, it helped a lot in exchange of experience in the dermatology among all the colleagues and learning from each other to improve our standard of care in our patients. As Dr. Yusuf mentioned, that we received 50 cases from local and international participants, and unfortunately, due to the limited of time, we couldn't accept more than 10 cases. For those who didn't have a chance to present them today, we would like to thank you a lot for sharing your cases and look forward to seeing your presentation, your interesting cases at one of our future events. And today we'll go we have the clinical presentation session. We have 1 and 2. One will be moderated by me and the other one will be moderated by Dr. Mohammed Al-Jasser. As you can see from the program that we have a lot to get through today. Before we start our first clinical presentation session, I want to remind all the speakers that we have maximum of 5 minutes for their presentation and 2 minutes for discussion. I want to ask all of the attendees to type their question in the question and answer box during the presentation, and the speaker will answer them during the discussion time. So now we can start with our first speaker. Will be Dr. Abdullah Al-Migrin. He's R4 resident from King Khalid University Hospital. Dr. Abdullah, are you with us?
Assalamu alaikum. Good morning, good evening, everybody from everywhere. I am Dr. Abdullah Al-Migrin, dermatology resident from King Khalid University Hospital. So should I start now?
Yes, Dr. Abdullah.
Do you see my presentation now? Is it clear? Dr. Hind, are you seeing my presentation right now?
Doctor.
We can see you, yeah. You can start, Dr. Abdullah.
So I am going to present the first case, which is for an 18 months baby boy who was presented to our clinic, pediatric dermatology, with sudden onset reddish brown skin lesions. Started in the face, then gradually enlarged and involved upper and lower extremities at age of 12 months. They were entirely asymptomatic. There was no history of fever, no history of weight loss, no behavioral changes, no change in appetite, no abdominal pain, no altered bowel habit, no consanguinity, no similar presentation in other family members. He was completely healthy. So on examination, he was a healthy baby boy who in general exam was vitally stable. There was no lymphadenopathy, no organomegaly. On the skin exam, there was multiple reddish to brown to gray nodules over the face and extremities, lower extremities and upper extremities. It was strikingly sparing the whole trunk. So after that, we decided to proceed with a deep bunch biopsy. The biopsy revealed diffuse mixed infiltrate in the deep dermis. The infiltrate were composed of multiple foamy histiocytes, plasma cells, lymphocytes, and this structure with the yellow arrow. This is another section, the same thing. So we did a panel of stains, which was positive for vitamin 10, CD4, CD68, CD163, CD100, and negative for CD1A. We did also some investigations, including CBC with differential. It was unremarkable. liver function test, renal function test, unremarkable. Lactate dehydrogenase was normal as well. There was elevated immunoglobulins, including immunoglobulin A, G, and E. The ANA actually was ordered by general pediatric specialty, and actually it was unremarkable. Urinalysis was unremarkable as well. The reporting pathologist actually, he reported that the histological features was highly suggestive of a deep-seated non-Langerhans cell histiocytosis lesions. The diagnosis of Rosé-Dorfman disease was established based on the clinical presentation and skin biopsy with the panel of stains. We did CT chest, abdomen, and pelvis, and it was negative for lymph nodes and internal organ involvement. The patient was referred to pediatric hematology accordingly. Tumor board conducted, and eventually wait and see management strategy was the agreed upon plan. So that's conclude the case. But the take-home message that I did some quick literature review. There was 263 patients published in the literature regarding the Rosé-Dorfman disease up to May 2018, in total of which 220 has cutaneous limited disease. The most common extranodal site for those which was not cutaneous limited disease is the skin. It has a very wide heterogeneous cutaneous presentation. Mean age is 47 years old with female predominance. Usually it is presenting with multiple lesions. The most common location was extremities. The best reported therapy is excision and or cryotherapy. The least effective modality was systemic steroid. I have just a quick stimulating question here from my case. What is the name of this dermatopathological finding with this yellow arrow? Is it A, B, C, or D? Tattoo giant cell, Langerhans giant cell, imperiopoiesis, or Schaumann body? You can type it maybe in the Q&A. So basically it is imperiopoiesis, which is linked more with Rosé-Dorfman disease. It is characterized by cell inside the cell. So we have a plasma cell inside the histocyte cytoplasm. Thank you so much. And if you have any question, please.
Thanks, Dr. Abdullah, for this interesting case. We are checking the question and answer to see the box, to see if there is any question. Till now, nobody seemed to be ready to ask the question at the moment. So I would like to ask, did you use for this patient a topical steroid, and do you think it's helpful in these cases? I know it's self-resolving, especially he didn't have any other extra cutaneous manifestation, but I mean, did you try any strong topical steroid for this case, and what do you think about that? Is it helpful or not?
Yes, actually we had a discussion with the family regarding the available treatment modalities. There is no much available treatment modalities. All the reported successful treatment was talking about excision and or cryotherapy. The family are not so bothered by the clinical presentation, and we offered for them the treatment, or we can do just wait and see strategy. It is reported that is less than 25% of patients with follow-up, with prolonged follow-up, they will resolve spontaneously. The follow-up period available in the literature is to 36 months. there's no data beyond this duration, whether it will dissolve or just will stay as it is.
Even though with here asking Ali Osam about topical tacrolimus, and I think the same answer.
Yes.
Okay. Why CT scan was indicated in this case for staging?
Yes, we are looking for internal involvement of rosacea hormone disease. So we want to make sure that there is no underlying systemic involvement, so that the management plan will entirely change in that case.
Most of the question you answered while you are presenting. And some of them, they ask about systemic steroid, but as you mentioned, you want to wait for C because he don't have another extra manifestation. So I would like to thank you, Dr. Abdullah, again for this good case, and we will go to the second speaker. Thanks a lot, and we will go to our next case. Thanks.
السلام عليكم.
Dr. Ahmed, can you please open your presentation from Zoom?
Okay. Yeah, I'm trying. أحسنت كتير.
Okay, we'll start with our second speaker. We would like to welcome you, Dr. Ahmed Al-Nassar. He's a consultant dermatologist from Armed Force Hospital from Khamis Mushaid. Dr. Ahmed, are you with us?
Hello, Assalamu alaikum.
Wa alaikum assalam. The stage for you.
Yeah, I am with you, but still I am trying to.
Okay, you share your slides? Okay,
Yes.
we'll give you time.
Dr. Ahmed, can you open presentation from Zoom?
Yeah, I'm trying.
Share your screen, please.
Yeah.
From Zoom.
Assalamu alaikum. Do you hear me?
Yes,
Yeah. Do you hear me?
yes, continue, please.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. And thanks a lot for the organizing committee for selecting my case as one of the cases to be presented today. It's my pleasure to present this case, which is actually a very rare case from Saudi Arabia. And it will be about fever with Berber crash and an eschar, a health problem that may be of concern. In April 2019, a 59-year-old Saudi camel shepherd from Riyadh province came to our hospital's ER because of fever, headache, skin rash, and cough. His skin rash started a few days after fever and chills. He was diabetic on insulin with no history of traveling abroad. He used to remove Gerdan or Korad, which is an Arabic word that in English corresponds to ticks. And this was from his camel's skin, as was seen in a video sent by the patient to us. On examination, his temperature was 38.5 Celsius, but otherwise he was generally well. He had a widespread Berber maculopapular rash sparing the face and mucous membranes. His dermoscopic diascopy showed non-blanchability of the rash. There was also a minimally irritating eschar on his back. Our preliminary diagnosis was fever with Berber rash and an eschar, secondary to a spotted fever rickettsiosis, or SFR. Our differential diagnosis was viral infection such as enterovirus infection and also small vessel vasculitis. He was admitted to our hospital and was thoroughly investigated. His basic laboratory workup showed neutrophil leukocytosis and lymphopenia, hyponatremia, and markedly elevated fasting blood glucose level and hemoglobin A1C. His negative and positive acute phase reactants showed remarkable change, indicating the presence of severe acute inflammation. His basic infectious disease and antinuclear antibody laboratory workup was unremarkable. However, rickettsial infection serology revealed high titers of rickettsia IgG and IgM, and also of rickettsia typhi IgG and IgM. This was explained by cross-reactivity between the rickettsia antigens and rickettsia typhi antigens, but not due to coexistent infection. His chest and abdominal pelvic imaging was unremarkable. eschar histopathology showed a wedge-shaped inflammatory process that extends deeply into the dermis, together with coagulative necrosis and other findings consistent with an arthropod bite reaction. And the tick Rhipicephalus sanguinus was the incriminated vector. Our final diagnosis was a spotted fever rickettsiosis, mostly caused by rickettsia. However, neither molecular testing such as PCR nor isolation in culture was performed. As to the treatment, he responded very well to oral doxycycline, 100 milligrams by ID for 10 days, but not to the other antimicrobials. And this is evident here in the figure. Of note, all medications were prescribed before rickettsial serology and histopathology results show. On reviewing the literature, we found that until recent times, tick-borne viral disease such as Crimean Congo and al-Khorma hemorrhagic fevers, but not bacterial ones such as rickettsiosis, were reported in Saudi Arabia. On May 6, 2019, our case was reported to the local office of the Infectious Diseases and Preventive Medicine Department, Ministry of Health, Khamis Mushaid. In August 2019, Elzin et al. Diagnosed another case of spotted fever rickettsiosis in a Saudi teenager from Riyadh province, again from Riyadh province. He was diagnosed as acute meningitis secondary to rickettsia after a camel's tick bite. Together, these two cases have to direct the attention to the presence of this infection in Saudi Arabia, especially in Riyadh province. Our take-home messages included spotted fever rickettsiosis should be considered in the differential diagnosis of fever and berberic rash with and without an eschar in Saudi Arabia. Further surveillance has to be performed to trace this infection, especially in camel shepherds, and that doxycycline must start once the disease is suspected to avoid complications, including death. And thanks a lot.
Thanks, Dr. Ahmed, for this comprehensive presentation.
Shukran. Thank you.
I'm looking for the question, if there is any question up here. Till now, there is nothing. So I like that you go with all the, it's really wide differential diagnosis here. And especially with tick-borne disease, it's a lot to think about it regarding bacterial or venous or viruses. But the things that it's coming in my mind when I see the first slide and with Kamal presentation, what about MERS virus? Do you think about it before you do the serology? I didn't see any serology about MERS virus.
Actually, it was done, but just I didn't add it here. But it was done for H1N1 and also for MERS-CoV.
Very nice presentation. I think we need to know these things because we didn't consider it in our differential diagnosis because of rarity that we always think that we didn't have rickettsia here.
Yes, sure. Yes, sure, you're right. And because of this, I just presented it in this forum.
There have some question arrived. So first question with why you request coagulation profile?
Yeah, this actually was just a routine thing done by our colleagues in the ID. They just were consulted and they asked for it.
Yeah, because even a lot of vasculopathy and it can be, and some of the viruses it end with called the IC. It can end with the IC. I think. Okay, the other question, what is the clue for diagnosis of your case?
The clue for diagnosis was, actually this was just a constellation of manifestations, but this diagnosis is presumptive diagnosis and is not a straightforward, very final diagnosis because, you know, we have to have PCR or culture, which actually are not available.
Okay. So here the question, Dr. Ahmed, how can we know for sure differential diagnosis for viral tick infection? So yeah. I think, yeah.
Yeah. Regarding other viral infections like enteroviruses or cytomegaloviral infection or also Epstein-Barr viral infection, they can be differentiated, but still the patient was having nothing else indicating such infections.
Yes. Here is the scar supposed to be anthrax? It's really wide differential diagnosis, I think.
You are right. Regarding the scar, it is a wide differential diagnosis, but the presence of this berberic rash together with the scar in addition to the history.
Yeah, I think here the history is the clue in your case.
Can help in the diagnosis.
Okay, I think now we go to the most of the answer. The other one is repeated. Thank you very much, Dr. Ahmed. We will go for our third speaker. Thanks a lot again. Okay. Should we go now to welcome our third speaker, Dr. Al-Hanouf bin Dakhil. She's a medical student of Imam Mohammed bin Saud Islamic University. Welcome, Dr. Al-Hanouf. Okay, you are ready. Okay, the floor is yours.
Thank you, Dr. Hind. Assalamu alaikum. Good evening, everyone. My name is Al-Hanouf bin Dakhil. I'm a senior medical student at Imam Mohammed bin Saud Islamic University. Today, I'll be presenting a case, and I think it's good timing after the excellent talk by Dr. Smith about oral diseases. So this case can present an example of that. So a 68-year-old female patient complains of oral mucosa redness, gingival swelling, loss of taste, and burning for the past 10 months. The patient had been evaluated by multiple providers, for example, primary care physician, general dentist, and oral surgeon. And she had been prescribed with chlorhexidine rinses and viscous lidocaine without any benefits. She has a sleep apnea, hypertension, type 2 diabetes, fibromyalgia, and GERD. She's taking amlodipine for her hypertension, gabapentin and tizanidine for fibromyalgia. However, she's not taking any medication regarding diabetes, not known to have any drug allergy, and she has a significant family history of leukemia. Both her parents were diseased from leukemia. Moving to the clinical picture, here we can see a significant erythema on vermilion border and the labial and buccal mucosa. Also, there is erythema of the hard and soft palate as well. The yellow arrow shows a white plaques that can be rubbed off during clinical examination, and there is erythema as well. Here on the second picture, we can see significant erythema and enlargement of the gingiva. And on the last picture, here we can see a glazed area as shown here, which suggests atrophy of the papilla of her dorsal tongue. For the investigation, so as I said, the patient was presented with whitish plaque that can be rubbed off during clinical examination. So this is just the the clinical presentation of candidiasis infection. However, the patient also presents with gingival swelling, which is not the usual clinical presentation of oral candidiasis. So we think that the fungal infection was incidence finding, and she has it because she's having secondary fungal infection, and it's not the primary that triggered her condition. So a biopsy was recommended for further evaluation. But before doing the biopsy, the patient was prescribed fluconazole for 14 days, which is antifungal infection. The reason for that, because we want to decolonize the area and eliminate the fungal infection to avoid any cellular and architectural changes that can be caused by fungal infection, and it could be interfere with the diagnosis. So for the differential diagnosis, it could be orofacial granulomatosis, leukemia infiltrate, since she has a strong family history of leukemia, and leukemia can present with gingival swelling. It could be plasma cell gingivostomatitis, lichen planus, and mucous membrane pemphigoid. For the microscopic view, here we can see low microscopic view shows spongiatic epithelium, as shown here. On medium power, we can see prominent vascularity. There is a lot of blood vessels, which suggests sign of inflammation. On high power microscopic view, we can see dense sheet of inflammatory cells, mainly plasma cells, without any mitotic changes. So based on the histological examination and clinical examination, the diagnosis is plasma cell gingivostomatitis. And it's thought to be hypersensitivity disease, which I'm going to talk briefly in the next slide. But for the patient management, the patient was prescribed Midrol packs starting with 24 milligram, and tapered down to 4 milligrams to decrease the swelling and the discomfort. Also, the patient was prescribed nystatin suspension, switch and spit for oral candidiasis prevention. And after completing the course of midroll packs, the patient was prescribed dexamethasone, oral solution, switch and spit for maintenance therapy and for treatment of the flares. Because plasma cell gingival stomatitis was thought to be hypersensitivity reaction, so the patient was advised to avoid flavored diet like flavored coffee and oral hygiene product like flavored toothpaste to avoid possible allergens. And this is an important point we should consider, since the patient has these conditions for 10 months, and she continues to have flares even though she avoided the flavored diet and oral hygiene products. So she was advised to do an allergy patch testing, including dental materials, to identify the specific allergen that triggered her condition. For the take-home message, plasma cell gingival stomatitis is a rare benign inflammatory condition of the oral mucosa thought to be hypersensitivity reaction, either from diet, medication, or oral hygiene products. And the main feature is infiltration of plasma cells. Plasma cell gingival stomatitis can cause a diagnostic dilemma due to non-specific presentation, and it can mimic many dermatological conditions. So biopsy is crucial for definitive diagnosis and to rule out many other conditions like malignancies. This is the end of my presentation. Thank you for listening, and I would love to answer the questions.
Thank Dr. Al-Hanouf. It's very nice presentation. Thank you for sharing. And it's good to be with the mucosa with Dr. Jenilyn and to add some of other diagnoses that it's so rare and we just hear about it. Till now, we didn't receive any question. Yeah, there is a question regarding leukoplakia. Does it remain? Oh, it's not related. Okay. So I have one question for you regarding the, as we know, this patient have a lot of risks like leukemia, and it's good to exclude all of that. And you give us the approach how to exclude all this risk factor, the candida, the nifedipine. My question about the nifedipine, because we know it can cause this hyperplasia of the gingiva. So do you think we know that it cannot cause the other manifestation that you mentioned and the biopsy result and the plasma rich? But do you think if we can remove this or we can replace it with any angiotensin or other medication of hypertensive can improve the hyperplasia of the tongue?
Yes, sure. But because the patient, as I mentioned, she had a family history of leukemia. So on biopsy, they did the biopsy of the gingiva. And when we do like staining, we can differentiate between the polyclonal and monoclonal. The patient, she's having polyclonal, which suggests it's a benign condition. But if she's having a monoclonal plasma cell, it can lead us and make us to think about malignancy of her condition.
Okay. I mean nifedipine, the calcium channel blocker. Did you ask the patient to change it or just to, maybe it can?
No, because the patient was taking these medications several years ago, and she didn't have any changes.
Especially with the histopathology of plasma cell, it's not one of the causes. So did you exclude, here one question, did you exclude syphilis? Maybe because you mentioned that the plasma, maybe this is the question. Why they mentioned
Yeah, we could do staining to exclude that. But mainly, since she's having polyclonal on the histopathology, so we put the top differential is plasma cell gingival stomatitis. And she has recurrence attacks.
Okay, thanks a lot, Dr. Al-Hanouf. We will go for the fifth speaker, Dr. Asma Swalim. Dr. Asma Swalim she's a R4 dermatology resident from King Saud Medical City. You are welcome, Dr. Asma. Are you with us?
السلام عليكم. أهلا دكتورة.
حياك الله.
Yes. الله يسعدك.
You can share your slides.
Sure. So I'm Asma Suaim, dermatology resident. This case was supervised by Dr. Novelade. So this is 22 years old female presented with 2 years history of asymptomatic lax skin, mainly over the neck, axilla, and hard ears. She had eye symptoms, which were myopia. GI symptoms were symptoms of gastroesophageal reflux disease and back pain. No history of bleeding or poor wound healing or tendency to bruise easily. She had a family history positive for consanguinity, and her sister has the same complaint. So these are the clinical pictures. As you can see, the neck shows lax skin. And for the ears, it was hard on palpation, especially over the earlobe, which was unusual. So generally, the patient looks well, not in pain or distress. The color of the patient is normal, and she's vitally stable. As we said in the local examination, she has lax skin over neck, axilla, and her ears, hard ears, and mucous membrane nails were not involved. So differential diagnosis, we can think of wide differential diagnoses that come with lax skin, like cutis laxa, Ehlers-Danlos syndromes, cutal syndrome, elastoderma, and late onset focal dermal elastosis, Costello syndrome, and finish type amyloidosis. So regarding investigation, we did for her skin punch biopsy from the left axilla. In low power, it shows normal epidermis, no significant dermal inflammation. In high power, it reveals thickened and calcified elastic fiber. So genetic testing was done on the patient. It showed homozygous mutation in the matrix gallopprotein, which is a non-SIRE mutation. The diagnosis was cutal syndrome. What the plan was to refer the patient to several to other teams, like pulmonology. They did chest X-ray. It shows calcification of the trachea and bronchi. For ortho, because of her back pain, they did spine MRI. It shows bioconcave appearance of the vertebral bodies, which may be an indication of sickle cell anemia. But when they did the hemoglobin electrophoresis, it was normal. For the GI, she's following them up because of the gastroesophageal reflux disease, and they are giving her proton pump inhibitors. For ophthalmologic, because of the myopia. For cardiology, they did for her echo. It showed left ventricular false tendon. For the plastic, the patient underwent face and neck left because of the lax skin, and she was happy with the results. They also did genetic testing on her sister because she had the same complaint, and she was positive for the same mutation. So the take-home message, cutal syndrome is a rare autosomal recessive disorder caused by mutation in the gene encoding the matrix gallopprotein. Age of onset is childhood. The prevalence is less than 1 in a million. There are less than 30 cases reported so far. Most of them are from Middle East. Diagnosis is usually suspected on the basis of clinical presentation, radiographic examination, and can be confirmed by genetic testing. The clinical features, the patients usually show abnormal calcification, principally over the cartilage of the ears, just like our patient, nose, larynx, and the tracheobronchial tree. And they can have dysmorphic facial features. And other association could be hearing loss, recurrent otitis, and or sinusitis, mild intellectual deficit, frequent respiratory infection, nasal speech, and rarely seizures or short status. Optic nerve atrophy and lax stuffy skin with prominent skin folds were reported usually around the age of 30 years. That's why our patient presented at the age of 22. For the management, mainly symptomatic, we focus about the pulmonary management, and the prognosis for most of the patients is good, but life expectancy depends on the extent of the pulmonary involvement. Thank you.
Thanks, Dr. Asma. Nice presentation for this rare disease. Does she have any dysmorphic feature, this patient? We didn't see
No, she does not have.
Okay, great. So because we are lacking the time, so we just go to our last speaker in the first session, Dr. Amal Al-Asmari. She's R2 dermatology resident from King Abdulaziz Medical City, Riyadh. If you can share your slide with us, Dr. Amal.
Yes, hi. Can you see my presentation?
Yes, great.
So I would like to thank the organizing committee for allowing me to participate in my case with you. So without further ado, this is a 39-month-old girl known to have Wolman disease, diagnosed in 2017 by molecular testing and manifested by hepatosplenomegaly, adrenal calcification, and severe failure to thrive. She was admitted to our hospital for enzyme replacement and referred to our dermatology service for these perianal erosions involving the buttocks and swelling of the labia majora, which was noticed 2 months ago, and it was progressing. Family history was positive for parents. They were first-degree relatives, and 2 maternal sisters. They had this similar condition, not treated, and passed away at 9 months of age. So upon examination, you can notice these diffuse firm erythematous plaques over the buttocks, and the perianal area, it shows these multiple erosions with knife cuts appearance around the anal orifice, and marked erythematous swollen labia majora. So our differential diagnosis include infectious process, autoimmune diagnosis, associated granulomatous reaction, sarcoidosis, and less likely foreign body giant cell reaction. We did biopsy to confirm. So our first impression and most likely diagnosis was Crohn's-like genital skin lesion. So to confirm and rule out other diagnoses, we did skin biopsy, and it showed epidermal hyperplasia and diffuse non-caseating granulomatous dermatitis, and there was also dense plasma cell infiltrate extending to the subcutaneous tissue. PAS and GMS staining were negative for fungal organisms, and there was no acid-fast bacilli seen in Zeeb-Nelson special stain, and TPPCR is negative. Also, no Leishmania de novo bodies were seen. CD1A is negative. So again, impression, Crohn's-like genital skin lesion. So the plan was to involve gastroenterology for assessment and evaluation of the patients, and they did endoscopy and took multiple biopsies. Examination of the upper GI biopsies, it revealed intraepithelial lymphocytosis in the esophagus and mild chronic non-active gastritis. And examination of the lower GI biopsies, it revealed features consistent with the involvement of Wolman disease of the GI, which was expansion of lamina propria with foamy histiocytes, xanthoma cells. Enlarged intestine, there was focal non-specific active colitis with no evidence of chronicity, and all biopsies were negative for granulomas. We treated the patient with the following topical treatment: fusidine PID for 2 weeks over the biopsy area and erosions, muconazole and hydrocortisone Dectacor 20% BID for 2 weeks over erythematous areas, followed by tacrolimus 0.1% BID. And after 14 days approximately, there was mild improvement of skin lesions noted. This is the patient after 14 days. There was mild improvement after the treatment I mentioned. So our plan was to continue tacrolimus 0.1% PID and consider oral metronidazole, and if it fails, maybe consider biological treatment. So as a summary, Wolman disease is rare inherited autosomal recessive storage disorder with only few reported cases worldwide. This congenital condition is caused by mutation in the lipid gene, which encodes the protein lysosomal acid lipase, and this protein is responsible for metabolizing cholesterol esters and triglycerides in LDL into free cholesterol and free fatty acids to be reused and metabolized by the body again. If there is decreased activity or deficiency of this protein, it leads to buildup of cholesterol esters and triglycerides in many cells and tissues like adrenal glands, liver, and spleen. And this accumulation of cholesterol esters and triglycerides in tissues, it will lead subsequently to tissue damage, giving rise to the clinical features that patients usually present with, like hepatosplenomegaly, adrenal calcification, malabsorption, vomiting, steatorrhea, etc. And patients usually present in early infancy, and without treatment, patients die within the first year of life. And the mainstay of treatment is enzyme replacement therapy, like our patient. Every 2 weeks, she's admitted to the hospital for enzyme replacement. And again, without treatment, they die within the first year of life, like the maternal sisters, they died in the first 9 months of age. So cutaneous Crohn's disease, also known as metastatic Crohn's disease, is a rare manifestation of Crohn's disease. It's defined by non-caseating cutaneous granulomatous lesions that are not contiguous with the intestinal Crohn's disease. So although cutaneous Crohn's is well recognized in adults, it's exceedingly rare in children. And the onset of the cutaneous lesions, it may develop either simultaneously or preceding the GI disease. With most cases of cutaneous Crohn's, they presented prior to the diagnosis of GI disease or GI Crohn's disease, like in our patient. However, upon literature review, no cases of Crohn's disease been reported in Wolman patients. Actually, the only skin manifestation reported in Wolman disease patients was this yellowish tint, which is jaundice from the liver fibrosis as the disease progresses. So thank you. I hope I wasn't fast. Thank you for listening, and thank you for having me here.
Thank you, Dr. Amal. Thanks for this comprehensive presentation. It's so nice presentation, and we will look for any question. Dr. Mohammed have a question here. Any concern about using tacrolimus in this case and increase the risk of malignancy associated with tacrolimus lymphoma, especially the affected area is relatively large to the child body? Would love to hear your thoughts on this.
Actually, we're not going to use it for very long. We just use it for a very short period to avoid the risk of malignancy and systemic absorption. And we also did tacrolimus level. I don't remember the number yet, but I will check.
Okay, great. Did you check any cases? There is any cases of any other storage diseases have a Crohn's disease or cutaneous manifestation of Crohn's disease, or any granulomas reported in other storage diseases?
To my knowledge, specifically Walman, I'm not sure about the other storage disease, but to my knowledge, Walman, no cases have been reported, and actually we are glad to report this case as maybe the only one yet known yet.
Thanks for sharing this case again, Dr. Amal. We come to the end of our second session or first session of clinical presentation. We will go for a break for about 3 minutes. After that, we will start our clinical presentation second session with Dr. Mohammed Al-Jasser. Thanks all. Wait us for the second session.
Okay, we would like to welcome you to the second session of the case presentation. I would like to thank all the speakers who did the first session, and we have 6 additional interesting cases. So for the sake of time, we'd like to start with the first case presentation, Dr. Hadil Al-Salim. We welcome you for your presentation, and you can kindly start as soon as you're ready. Is Dr. Hadil with us?
Yeah.
تفضل Dr. Hadil.
Good evening. Hello, everyone. I would like, first of all, to thank the organizers of this meeting for inviting me here today. I'm here today, and I'm Hadil Al-Salim, and I'm here today to present our case. A 35-year-old pregnant woman came to the clinic with a 5-month history of multiporotic red to brown papillonodules on the right posterior auricular regions, as shown in figure A. The lesion had gradually increased in size, measuring 3 by 3 centimeters at our first observation. Bleeding was observed when scratching and combing her hair, especially in hot climate. The lymph node examination was unremarkable. There is no history of trauma or atopy and external otitis media. There is no history of allergic conditions or medication use. Routine laboratory investigations were done, including complete blood count with differential, renal and hepatic profile, and thyroid profile were all within normal limits. In figure 1A, deep skin punch biopsy revealed a cluster of blood vessels as shown here, and thick wall endothelial cells with a background filled with eosinophil and lymphocyte. Therefore, the diagnosis of pharynglymphoid hyperplasia with eosinophilia has been made based on the clinical and histological findings. The treatment has postponed 2 months post-delivery. The patient returned to the clinic, and there was no change in the size or number of the lesions. And based on the nature that pharynglymphoid hyperplasia with eosinophilia is a vascular origin, we decided to treat the patient with topical timolol maleate solution drops 0.05% twice daily, 2 to 3 drops each time. And 2 weeks later, the dosage was gradually increased to thrice daily. During the 3-week follow-up, the lesions were of the same size, with only a modest change in color from purple to dark brown. This color change suggests actually that timolol was a potential treatment option, but likely require more efficient delivery into the tissues. That's why we consider laser-assisted drug delivery, and therefore we added the fractional erbomiag laser to the management plan once a week. The patient was instructed to apply topical timolol maleate solution drops 0.05% thrice daily, immediately after and between the laser session. 5 laser sessions were provided over 5 weeks, and the laser parameters were as follows. In the first session, the fluence was 12 joule per square centimeters single pass. The second session, the fluence was 14 double pass. The third session, the fluence was 16 double pass. And the fourth session, the fluence was 18 double pass. And the last session, the fluence was 18 joule per square centimeter triple pass. The lesion gradually decreased in size and completely disappeared after the 5th session, as shown in figure B. Pharynglymphoid hyperplasia with eosinophilia can have a spontaneous remission, but symptomatic and disfiguring lesion may require treatment. It may lead to poor cosmetic outcomes that may impact the patient's psychosocial well-being, resulting in further aesthetic procedure. Although different treatment modalities have been reported for the management, it has around 33% relapse risk rate, in which almost the cases were treated by surgery. We would like to highlight this case because it could encourage the treatment with topical timolol and erbomiag laser, which is a therapeutic approach that still offers the advantage of being simple to perform and much less invasive than the surgical approach. while in the same time, it achieves similar results in terms of reoccurrence and even better aesthetic outcomes. Thank you for listening.
Thank you.
Question?
Thank you very much. Very nice therapeutic pearl. Just see if we have questions. Okay. So the question is about the difference between angiolymphoma hyperplasia, eosinophilia, and tumoral disease. What's the difference between angiolymphoma hyperplasia and tumoral disease?
Yeah, tumoral disease actually is a chronic inflammatory disorder. It's characterized by a triad of eosinophilia and elevated level of immunoglobulin A and pale subcutaneous tissue. It's also accompanied by regional lymphadenopathy, and it's associated more than angiolymphoma hyperplasia with a nephrotic syndrome.
I have a question for you. Why did you start increasing the doses of laser? If the aim is, from what I understood, is to increase the delivery of timolol, right? You use fractional laser to increase the delivery of timolol. Why did you have to increase the fluence with every session?
We started with a lower fluence, 12 joule per square, then gradually increase it to guide the patient response.
Okay. And the reason you're asking about the role of erbium laser is probably to increase the delivery of timolol, because you tried it without and it didn't help much, right? Then when you added the laser, you saw results.
Yeah, right.
Perfect. Okay, so I think for the sake of time, we'll move on to the next case. Dr. Ibrahim Al-Fareh, you can kindly present your case, and just a kind reminder to stick to the 5-minute time for each session. And it's also good to have more questions.
Assalamu alaikum. I have my voice here. Hello, and thank you to Saudi Society of Dermatology and Dermatosurgery for allowing me to present this interesting case that I faced in my call in King Fahd Medical City. And thank you, Dr. Muhammad, for moderating this session. Allow me to share my screen. I hope the presentation is visible to you all.
It is visible, you can go ahead.
Okay. So my name is Dr. Ibrahim Al-Fareh. I am R3 dermatology resident in Riyadh, joined the program. So basically, this is a 45 years old man. He's in a case of hypertension as well as cadaveric renal transplant 1 year before his presentation to the hospital, which is secondary to end-stage renal disease due to his hypertension. He was admitted electively to the hospital for lung nodule for investigation. Upon admission to the hospital, he developed a fever on his third day on admission, which reached 40, associated with chills and rigors, which progressed to involve to include hypotension, tachypnea, as well as desaturation the next day. And then he was ICU admitted as well as intubated. Then a week after his ICU stay, we were consulted for skin lesions that are mainly over the back. Unfortunately, we are not aware about the duration, progression, symptoms, and if there is any previous similar presentation of this lesion due to his current situation. He's chronic heavy smoker for around 20 years. The family denied any history of recent travel or contact with any sick patients before his hospital admission. He did not start any new medication or did not use any illicit drugs. His current medication include tacrolimus, Celsep, prednisolone, as well as valganciclovir and antihypertensive medication. You can see here on the right side the clinical picture of the lesions. On a close inspection, he is in a prone position, intubated with the unfortunate GCS of 9 out of 15. His temperature was 37.4 and his blood pressure was 110/65. His heart rate is slightly elevated, and his respiratory rate was within normal. And we can see in this picture multiple hemorrhagic pustules and vesicles, mainly over the back. On total body skin examination, showed a similar lesion over his right calf. There were no hair, mucosal membrane, teeth or nail changes or palmoplantar lesions, and no palpable lymph node were palpated in supraclavicular, axillary, or cervical, neither organomegaly. So to be frankly honest, when I first assessed this patient, I did not know what I am dealing with. Is it an infectious agent? Is it a vascular lesion? Or is it a tumor? In the first assessment, a constellation of his ICU admission as well as a fever. I put in my first differential as infectious causes, which include herpes zoster, disseminated herpes zoster, since he is on tacrolimus and Silcept, or could be varicella, ecthyma gangrenosum, bacillus angiomatosis, or deep fungal or atypical mycobacteria? Or am I dealing with Kaposi sarcoma or other vascular lesion like pyogenic granuloma or cherry angioma, which was just recently picked? So his investigation include shown a leukocytosis of 27,000 with mainly a neutrophilic with many neutrophils. His LFTs were within normal. His creatinine was elevated, which was not recent. His lactate dehydrogenase is elevated. ESR and CRP inflammatory markers were elevated also. His quantiferon TB, hepatitis B, C were negative, and his blood culture as well as throat and bronchoalveolar lavage culture were not resulted yet. His CT chest showed a mass which measures between 5.7 centimeter and by 4 centimeter, which was reported to be infectious versus malignancy, which could help us a little bit in narrowing the differential diagnosis. So I took 2 bunch biopsies for routine hematoxin and leucine, as well as cultures for bacterial, mycobacteria, and fungal, as well as...
Dr. Ibrahim, sorry, but it's 5 minutes, so if you can go to the main things, please.
Sure. I took swabs also for infections. The biopsy were resulted showed intraepidermal vesicles with focal epidermal necrosis, as well as dense acute inflammatory infiltrate with nuclear debris. GMS stain showed filamentous branching beaded structure within vesicles and within the dermis. So the biopsy culture showed nocardia species, which was confirmed by the blood and as well as the sputum culture. Our diagnosis was disseminated nocardiosis. Fortunately, this patient was already covered by the appropriate antibiotic covering nocardia species. So in a term of literature review, I found 2 cases that were reported in the literature which has hemorrhagic vesicles. So my take-home message, generally in assessing these patients who are chronic immunosuppressed, your differential diagnosis should include infection as well as malignancy. And you should group the patient systemic as well as cutaneous presentation in one category, rather than multiple conditions. So this concludes my presentation, and thank you all.
Excellent presentation on a case that we don't commonly see. We don't see this regularly. It's a treatable case. Let's see if we have any questions. So there are no questions there. My question is, was there any results of what specific species of nocardia?
So unfortunately, it was not resulted which subtype. But all in all, nocardias asteroides is the most common, which is as a disseminated nocardiosis, rather than nocardia brasilis, which is mainly a cutaneous presentation. But unfortunately, the microbiology did not report which subspecies of nocardia.
Do you know from the literature which ones are common in Saudi Arabia?
Unfortunately, I don't.
Okay. That's interesting. Okay, thank you very much, Dr. Ibrahim.
Thank you, Dr. Mohammed. Have a great day.
You too. We'll move on to the next presentation by Dr. Maha Fahmi. Dr. Maha, you can kindly put your slides for our presentation. Dr. Maha, you're with us?
Yes, I'm with you. Can you see my presentation?
I can see you, but I don't see the slides yet. I can see you in the present, but I don't see your slides in the screen.
Let me check it.
Take your time.
Can you see it right now?
No, unfortunately.
From Zoom, Doctor. From Zoom.
Sorry?
From Zoom.
I'm on the Zoom already.
Do you have your PowerPoint presentation open in the desktop?
Yes, it's on the desktop, but I do not know what.
Did you click on the share screen, the green one?
Yes, I
What
checked
do you see in the screen when you click on the share screen? What appears?
Nothing. It appeared my presentation. That's why I
Good. Click on that presentation. When you click on share screen, click on the presentation.
No, that's what I'm doing, but I think you said that it's not appearing. That's why.
When you click on it, then play, then it will appear.
Can you see it right now?
No.
Let me log out and log in once more. I do not know. Maybe the problem is because I'm doing it from here. I'm going to log out and log in once more. Okay.
Maybe try another time. When you click on share screen, the green one, what appears in the middle of the screen? What do you see?
Yes, the presentation.
What do you see when you do that?
Can you see it right now?
It is starting, maybe to, yeah, go ahead. Now it's fantastic.
Yes, it's okay.
Just play now. Yeah, perfect.
Okay. So thank you, first of all, Dr. Mohammed, for this opportunity. Without further delay, I'm going to start with my presentation. I'm going first to say my statement of ethics that this presentation was presented in compliance with all confidential and ethical guidelines and principles. Patient biopsy for patient consent for the biopsy and photography was obtained at the time of the care. A 4-year-old child was presented to the clinic with these verrucous perianal lesion of 3 months duration with progressive course. Further questionnaire of the mother, she stated that the child used to go to the nursery a couple of days a week. So my differential was either condyloma acuminata or condyloma lata with a possibility of child sexual abuse. Biopsy was only performed for medical legal issues. The histopathology revealed that the dermis was infiltrated by sheets of discohesive round cell with reniform nuclei and nuclear infolding. Also, the infiltrate shows eosinophil, lymphocyte, and plasma cell. These cells was negative to pancytokeratin, but they were positive to CD1A and S100 protein. So the diagnosis was made Langerhans cell histocytosis. Langerhans cell histocytosis is a rare disease of unknown etiology caused by colonial proliferation of Langerhans cell. Langerhans cell histocytosis, its childhood incidence is 1 every 200,000, while the incidence is in adult is extremely rare to become 1 or 2 in a million. Langerhans cell histocytosis may be present with solitary lesion in the bone or visceral organ, in addition to the involvement of multi-organ system. Returning back to our case, imaging and blood workouts were done so as to rule out any systemic involvement, and all results were normal. So the child was treated with imiquimod cream, which was used for 2 successive weeks and resulted in complete cure of the lesion. Langerhans cell histocytosis involving the perianal skin is rare. Searching the literature, only 17 cases were reported. Out of these 17, only 4 cases, including this case, where the perianal lesion was the only and cardinal symptom of the Langerhans cell histiocytosis. Where in 207, Mango Itar reported a case, 211, Chokoi Itar reported another case, and the last case was reported by Dr. Amani and Dina Toya in 217. To your kind knowledge, these three cases, the presentation of the perianal lesion was an ulcerative lesion, which is a little bit different from my case, which is a verrucous lesion. So my take-home message is, although case reports are in the base of scientific evidence hierarchy, they provide resources of unusual information that may lead to advances in clinical practice. And as always said by Dr. William Osler, always note and record the unusual, publish it. Such information are always of value. And thank you.
Very nicely and clearly presented. Thank you very much.
Thank you, highly appreciate it.
And very interesting that the treatment ended up being similar to warts.
Yes, that's it. It was to do cryo, but started MQ mode.
But you ruled out systemic involvement, so that's
yes,
very
that's it. That's it. That's it.
Let's see what questions we have. Was syphilis? Was syphilis test done?
No, it was done. It was not done because the biopsy already revealed the Langerhans cell, so no need to do further investigation.
Okay. There are cases reported in the literature, several reported of Langerhans cell histiocytosis mimicking molluscum, but warts I haven't came across.
Yes.
So this is the only one, right? And what?
Yes, this is the only one. And also, by the way, the literature review as regarding the molluscum, they have a systemic involvement, not cutaneous.
As well.
That's
okay.
Yes.
And what made you suspect? What made you biopsy this?
For a medical legal issue, because we have to notify, because he's a 4-year-old child. That's why. So as medical legally only, I did biopsy it for medical legal issue.
Do you have any reports of Langerhans cell histiocytosis responding this fast to imiquimod?
No, I didn't. I checked in the literature. I didn't find anything. And even the three cases, the three cases I did mention, they were treated by thalidomide and methotrexate. None of them. Yes.
There's a question. Why, doctor, you did biopsy? Oh, yeah. So that's answered the question for medical legal. Is it possible that the patient had both features of both warts and infiltrative Langerhans cell histiocytosis? Were that looked at?
Actually, the clinical completely worked, but the histopathology from the upper and the lower lesions, the biopsy revealed histocytes. It was revised once and twice. So that's why I like to share it with you.
Very interesting. Very interesting. Thank you very much, Dr.
Highly appreciate
it. Thank you so much.
Bye-bye.
Okay. So we'll move on to the next session by Dr. Muna, next case, by Dr. Muna Shahri. So Dr. Muna, you can kindly present your case. Dr. Muna, you're with us?
Hello, everyone. Hi, can you hear me?
Hello. Yes, can hear you very well.
Yes.
Go ahead and share your slides with us.
Just a second. Can you see it?
Not yet.
Hold on. Okay. Is this good?
I don't see it.
You don't see it?
Just again, the green thing on the screen. Click it again and check. Is your and you can see your maybe the cam. Is the PowerPoint file open?
Yes.
Okay. Click the share screen again. Okay, maybe now it will appear. Perfect.
You see it?
Go ahead. I do. Perfect.
Okay, perfect.
Go ahead.
Bismillahirrahmanirrahim. Hello, everyone. My name is Muna Al-Shahri. I'm a medical intern from King Saud bin Abdulaziz University for Health Sciences. Thank you for having me today. Today, I'll be presenting an interesting case I had the chance of following with Dr. Abir Al-Sarhid at the National Guard Hospital in Riyadh. Okay. This is a 39-year-old male with no significant past medical history who presented with low-grade fever and fatigability. He presented to National Guard Hospital ER with 2 weeks history of the symptoms. This was associated with a pruritic eruption on his trunk and upper extremities for 2 weeks. As you can see, there are multiple confluent violaceous papules and plaques on the back area, with evidence of central epidermal detachment and a bit of scaling, as you can see in the zoomed in picture. There's also involvement of the nape of his neck with these target-like lesions. There's also involvement of his central chest with similar lesions. They were erythematous to violaceous papules with some lesions demonstrating central necrosis and others with tense hemorrhagic vesicles. He had minimal or few lesions on his face, a necrotic plaque on his mucosal lip, the upper mucosal lip, and a solitary necrotic plaque periorally. However, he had no other intraoral lesions and no ocular or genital involvement. He also had significant involvement of his axillary fold with sparing of the vault area. You can see there is evidence of violaceous dusky plaques that are studded with the tense blisters on the periphery with a sparing of the central area, and both axillas are affected symmetrically. He also had tense bullae over his dorsal hands and distal forearm on a background of a violaceous erythema. There was sparing of both palms and feet, no typical target lesions on examination. Hair and nail exam was non-significant. Upon the review of his systems, he had rhinorrhea, sore throat, nausea, joint and muscular pain. His past medical history was unremarkable. He received 1 dose of cefuroxime and acetaminophen few hours prior to the onset of rash by his family physician due to the vagueness of his symptoms. Otherwise, he is not on any regular medication and he had no known drug allergies. So given the vagueness of his symptoms, skin manifestation and musculoskeletal involvement that's been going on for 2 weeks, he was admitted to National Guard Hospital. His labs were only significant for mild anemia, neutropenia, and elevated ALT and AST with increased inflammatory markers. Interestingly, his serum IgA was elevated at a level of 8. His infectious and connective tissue disease workup was unremarkable. He had no evidence of monoclonal gammopathy, and blood smear showed no evidence of abnormal cells. To further investigate his condition, a skin biopsy for H&E and direct immune fluorescence was done. As you can see on low power, the epidermis was unremarkable. Evidence of neutrophilic infiltrate along the dermo-epidermal junction and perivascularly. A close-up here is showing evidence of focal subepidermal split, as you can see it here. And his direct immunofluorescence showed linear deposition of IgA along the epidermal basement membrane. So based on the clinical findings, especially those annular lesions with central clearing affecting his axilla with cluster of jewels, plus the histopathological evidence of neutrophils along the dermo-epidermal junction and the DIF findings, we reached the diagnosis of linear IgA bullous dermatosis, or LABD for short, presenting with target erythema multiforme-like lesions. An unexpected finding was also observed. His blood culture on the 7th day grew gram-negative cocobacilli, and the culture was positive for Brucella species. We believe the underlying trigger in this patient for his LABD is brucellosis, especially that we ruled out infectious, connective tissue diseases, hematological malignancies, and medication-induced LABD. making this one of the very few cases reported in the literature of brucella-induced linear IgA bullous dermatosis. He was referred to infectious diseases and was started on doxycycline and rifampicin. 1 week into treatment, he developed no new blisters and the old blisters healed. And he continues to be in remission 6 weeks post-antibiotic initiation. As you can see, such an impressive improvement within 1 week of starting antibiotics. He has residual dyspigmentation, however, no new blisters on exam. So take-home message for this case. As we saw in our patient, LABD can present with erythema multiforme-like lesions, and it should be included in the differential diagnosis of such lesions. Brucellosis should be considered as a trigger for LABD, especially in an endemic area such as Saudi Arabia, as there are 70 cases reported per 100,000 per year. Treating the underlying trigger can control LABD and cease further blistering without the need of immunosuppressive medication. This was my presentation. Thank you very much. I'll be happy to answer any questions you have.
Thank you, Dr. Muna. We actually have a few questions. So one question says, why did you perform IgA? And I assume it is serum IgA.
So the presentation of the patient, he showed a significant, he showed a unique pattern of the, especially in the axilla, where there was central clearing and only peripheral involvement. And he had vague symptoms, and he wasn't recently started on any medication. So making this part of the workup that we did infectious and connective tissue disease, as well as serum IgA.
So serum immunoglobulins can give a general indication about different autoimmune blistering diseases. So maybe that was it. That's why what was done. There's another question that this patient presented during the COVID pandemic, and if yes, was there a screening for COVID for this patient? Was it done?
Yes, he was COVID negative.
Good. And as you know, linear IgA, when we see it, we mainly suspect medication. So this one of the attendees asking, is there any role of cefuroxime as a cause?
Thank you for asking this question. Actually, cefuroxime was started hours before the rash developed. As we know, the drug eruptions happen or need at least 24 hours to occur. His antibiotics was prescribed to him hours before the rash.
So very short time.
Yes.
How many cases did you find associated with brucellosis with linear IgA?
To my knowledge, I only found one.
There is one?
Yes.
Which journal?
I found it in PubMed. I will check back and come back to you.
Great. It is an excellent case. Good luck with reporting this.
Inshallah. Thank you so much.
Thank you. Okay, let's move on to the next case by Dr. Taif Arweli. Dr. Taif, you with us? Yes, you can see the files. Dr. Taif, is this your desktop?
Can you hear me now?
Voice is a bit far.
Hello?
I can hear you, but it's a bit far. Your voice is not that clear. Is this your desktop you're looking for the file in?
I'm sharing my slides now.
If you can do something about your mic, so we can hear you better.
Okay. Can you hear me well now?
It's better, but it can get. We want to hear you even better than this.
Hello, everyone. Can you hear me now?
Can hear you, but it's still far.
Still?
Yeah. Are you speaking through the mic of the laptop or you have your headphones?
Yes, from the laptop.
Okay, just get closer to the laptop then, if you don't mind. And do you kindly play your presentation now?
Okay. Can you see my presentation now?
Yeah, we can see it and actually hear you better now. So you can go ahead.
Hello, everyone. My name is Tafir Wali. I'm a medical intern from High University. Thank you very much for accepting my case. It's my pleasure to join you today to talk about one of interesting cases. Let's start our case today. A 25-year-old lady, otherwise healthy, she showed up at the dermatology clinic with a long history of scalp growth since 1 year. She is assuming that appeared from hair transplant surgery that done in Turkey 6 years ago. The condition started as a small wound in the middle of the scalp with pus oozing and pain, and she noticed her hair did not grow back. We did examination, as you can see here. There is large ulcer in vertex area surrounded by hypertrophic scar and ulcer border with numerous follicular pustules and yellowish crust in surrounding area. We have a lot of differential diagnoses, including scarring alopecia, infection, malignancy, and pemphigoid. Scarring alopecia in form of erosive pustular dermatosis, like planopilaris, and discoid lobus erythematus. Infection, it might be fungal infection or bacterial infection. Malignancy, squamous cell carcinoma. The final differential, Alveolus pemphigoid, it might be pemphigus fugitans or secretial pemphigoid. We did a biopsy and showed that scarring alopecia with extensive lymphatic infiltration, there was no evidence of fungal infection. In the presence of large erosion in vertex area with the scarring alopecia, the most likely diagnosis is that erosive pustular dermatosis of the scalp. We put her on management plan, prednisone 30 milligram and hydroxychloroquine 200 milligram BID and intralesional steroid. Here's the scalp looks different than the previous photograph. This photo after course of treatment, as you can notice here, the size of ulcer was decreasing and started to heal from the periphery. Also, there is hair regrowth in surrounding area. Unfortunately, this photo after she stopped the treatment for 5 months duration, the ulcer expanded and now she has the largest size ever she had. We searched the literature and there is single case report of erosive pustular dermatosis of scalp arising after hair transplant surgery. This is patient, a 35-year-old man, developed erosive crust, plaques in his scalp 9 months after her hair transplantation. Despite treatment with topical and systemic antibiotic, the ulcer enlarged gradually. The patient was started on topical steroid, which resulted in significant improvement, and also oral zinc sulfate. 3 studies had been conducted on 26 cases with lichen planopilaris after hair transplant surgery. They showed that the majority of these patients have the same clinical representation of a classical LPP. At the end, I would like to give a message to the audience that summarize our case. First of all, scarring alopecia secondary to her hair transplant are rare. And there is a single case of erosive pustular dermatosis following transplant. And there is many cases of lichen planopilaris following hair transplant surgery. Scarring alopecia after hair transplant is very, very rare. Please keep that in your mind. Early diagnosis and intervention can preserve the hair follicle and change the course of disease if treated aggressively. In any case of a chronic inflammation, the area of transplantation should have a high index of clinical suspicion of a primary and secondary sclerotial alopecia. Finally, I'm done presenting, and I will pass the mic to the audience if there is any question. Thank you.
Thank you very much, Dr. Latif, for an interesting case. So we have some questions. So one question is, can you transplant hair into scars? But I assume the patient did not have scars initially. It was just regular transplant.
Yes, you can transplant, but depend on what type of scar you're transplanting it. Essentially, you should do a biopsy to confirm there is no disease activity.
Okay. Which you had in your case, there was disease activity.
Yes, there is disease activity.
We still have time for like 2 more questions. What is the one question we had? How did you confirm your diagnosis that it is erosive pustular dermatosis of the scalp? On what basis?
Based on biopsy, we can never exclude the diagnosis of lymphatic scarring alopecia, but always we go with the clinical and histopathology. This clinically is unlikely to be present in another cases, for example. Scarring alopecia with pustules and yellowish crust, and most coming with neutrophilic scarring alopecia, and come also with erosive pustular dermatosis. This is our working diagnosis. We cannot never be sure, and unless we repeat another biopsy.
Okay. There's a question, what's the relation between hair transplant and this presentation? In other words, possibly, is there a mechanistic explanation for why hair transplant caused this particular pattern in this patient?
Another pattern?
I mean erosive pustular dermatosis. You say there was another case, right? Reported.
Yes.
Is there any explanation for the mechanism? Why would hair transplant trigger erosive pustular dermatosis?
Based on literature, there is a immunological abnormality and genetic factors as the literature review.
Okay. And did you do DIF for your case, direct immunofluorescence testing?
No, we did not.
Okay. Topical treatment that was used in your case, which topical treatments? I saw mainly systemic. Was
intralesional
used other than intralesion, topical steroids, tacrolimus, topical? Any of that was used?
I'm not sure really exactly.
There's a question about whether the transplant was done in Saudi Arabia or abroad. It was done in Turkey, right?
Yes, in Turkey.
Perfect. Thank you very much, Victoria. Much appreciate, Dr. Latif. Thank you very much. Okay, so we'll move to the last case of our session by Dr. Zahir Omar. Dr. Zahir, are you with us?
Yes.
Can you share with us your presentation? Perfect. It's very clear. And you can kindly go ahead.
Good evening for everyone. I'm Dr. Zahir Mohammed Al-Noor Umar. I'm Associate Consultant Dermatology, King Abdullah Medical Complex, Jeddah. It is my honor to present today a 26 years old Saudi male not to have any medical illnesses, presented to the ER in the medical aspect of with the skin lesion in the medial aspect of the right thigh and lateral aspect of the left side. The lesion increased in size and started to discharge a clear fluid. Then swelling, and the patient developed pain, redness, and feeling of tickling beneath the lesions. No personal or family history of similar lesions before. He is a physician working in Alp village at Asir province. At the ER, the patient diagnosed initially as a case of multiple abscesses and planned for incision and drainage. But unfortunately, it is not done. Dermatological consultation was requested. In the ER, the patient is fully investigated with a complete blood count, which shows normal white PCs, normal eosinophilia, and no other abnormalities. Liver function test, renal function test, all within the normal range. On examination, as you can see in the image, the general condition of the patient is well. The patient is febrile, and in the image you can see the lesion, the skin lesions in the medial aspect of the right thigh and the lateral aspect of the left side. There is two tender erythematous follicular nodules with the central punctum, one in each thigh. The size of each lesion is average about 2 by 3 centimeter. The systemic examination of the patient is unremarkable. The first impression of this condition, as I mentioned, in the ER, the differential diagnosis was put at the cases of multiple abscesses, furunculasis, infected insect bite, arthropod, and foreign body reactions. The diagnosis and management. The diagnosis of myiasis was confirmed after the patient showed us the larva. The patient is a physician and he tried to put topical antibiotic at the first when he noted these lesions. And when he put this antibiotic, one larva get out and he's unfortunately bring it with him to the ER. At the dermatology, as a dermatologist, when we consulted and see the patient, we noted the larva, we suspect a diagnosis of myiasis and trying to help the patient to do a bedside maneuver to emerge the possible larvae if it is present. So with the occlusion and suffocation was done by placing a petroleum jelly over each punctum in order. After 5 minutes, one larvae emerged spontaneously and pulled out by the gentle removal with the untossed arterial forceps. We wait more, but no more larvae getting out. So we discard the patient home with a topical and systemic antibiotic to prevent any possible secondary infection. We follow up the patient with the photos and all the lesions rapidly resolved completely after 3 weeks. Here, the first, we apply the petroleum jelly in order to specify the larvae. This is the larvae which is getting out. This is for after 5 days follow-up of the patient. Just, you can see here, all the inflammatory process subsided, just the mild erythema around the punctum, and after 3 weeks, just mild crust in the area of the punctum. I show you, this is video. We did this maneuver bedside in our ward. Here we can see the active and live larvae moving. So we confirm the diagnosis and help the patient Take home message. Multiple cases of meiosis were registered in Asir province. Another few cases were reported in Jizan and Al-Baha and Hail cities. Awareness of the diagnosis and management of meiosis should extend to the healthcare providers. High index of suspicion should be considered in cases with the history of the possible traveling of the possible tropical endemic areas. Individuals traveling to that area should be covered all the times, long shirt, pants and hats at night, and sleeping on raised bed and increasing room and under mosquito net. Insect repellents are also recommended. That is all, and thank you.
Thank you. Thank you, Dr. Zahir. We have time for one question. Why systemic ivermectin was not initiated?
Really, we, as a dermatologist, we believe that the most simple, the most convenient treatment is a priority. So we try to help the patient with the very minimum procedures, minimum medications in order to avoid unwanted or abuse of medications. The diagnosis conferred by the larva bring by the patient, and we're sure that is a case of meiosis. So the management is obvious, is to try the very simple maneuver, which is the extraction of the larvae, and we're waiting for many times to allow another larvae to get out. We suspect that there is no other larvae, so no need for ivermectin or any anti-helminth treatment.
Thank you. Thank you. We have other interesting questions, but for the sake of time, we actually have to conclude our session. Thank you, Dr. Zahir. Much appreciated. So I thank all the attendees and presenters for the excellent cases. And now it's time for the announcement of winners, voting and announcement of award winners. And that will be by Dr. Yusuf bin Hamir. So I'll actually give the mic to Dr. Yusuf now. Thank you very much.
Thank you, Dr. Muhammad. Thank you, Dr. Hind. Thank you for everyone who are staying with us. Thank you for the presenter and their mentors as well. We had 11 cases, which are very interesting cases. And now we'll start the voting. We will divide the voting into two parts. The first part, you're gonna vote for the first 5 cases. So we're gonna see the first 5 cases and you're gonna vote on the best case. Okay, and then we're gonna go to the second part, which is for the next 6 cases. So can we have the voting for the first 5 cases, please? So you will have in your screen the voting, and then we're gonna see now a review of all the cases, just to remind you. And now we'll see the cases. Can you move on with the cases? Let's see. This is the first case, Rossi-Dorfman disease. The second case, spotted fever rictiosis. Third case, plasma cell gingivitis and stomatitis. The fourth case, Wolman disease. And the fifth case, Kutel syndrome. Please choose the best case from 1 to 5 up to Kutel syndrome. Okay, just choose from 1 to 5. Can we go to the first case, please? So the first case, Rossi-Dorfman disease. Second one, spotted fever rictiosis. Third one, plasma cell gingivitis. And the fourth one, Wolman disease. And the fifth one, Kutel syndrome. So choose the best case. 1, 2, 3, 4, and 5. Take your time in choosing the case, and we will go to the second part in few seconds. Take your time to vote for the cases. This is for the first part of the cases, for the case 1 to case 5. For the case 1 and case 5, now you can vote for the first part, and then we're gonna go to the second vote. So the first one, choose the best case you have: Rosy-Dorfman disease, spotted fever rictiosis, plasma cell gingivitis and stomatitis, Wellman disease, or Keutel syndrome. Choose the best. Scientifically wise. So, a few seconds and we will conclude the first voting and we'll go to the second voting. So everyone is excited to know who's the first place, second place, and the third place. Once we have the best case from the session 1, they will go into the final voting with the chosen one. So now, the voting for the first session is almost ending now. So now we'll go to the voting for the second part. Please, let's have the voting for the second part. So we have the result for the first session now. The first session, it's spotted fever rictiosis, followed by the plasma cell gingivitis and stomatitis, followed by Rosy-Dorfman disease. So these 3 cases will go into the final voting. The final voting will be the top 3 cases from first one, because there is, if you can go back to the result to see it again. Yes, this is the result. Let's see by number. Okay. So then the first place, spotted fever rictiosis, Dr. Ahmed Nasser, 369 vote, followed by 319 vote for plasma cell gingivitis, Dr. Al-Hanouk, followed by Wellman's disease for Dr. Amal Al-Asmari, 276, followed by Dr. Abdullah Migren, Rosie Dorfman disease, 270, and then followed by Dr. Asma Swalim, Cutil syndrome. So the top three places, they will go to the final voting. So now let's go to the second part. The second voting. So in the second part, please select your choice, the presentation from cases 6 to case 11. The first case, angilymphoid hyperplasia, treated with timolol and fractional erbium laser. The second case is disseminated nocardiasis. The third case, Langerhans cell histiocytosis mimicking genital wart, followed by linear IgA bullous dermatosis triggered by brucellosis, and erosive postodermatosis of the scalp versus lichen planopilaris after hair transplant, and finally, the myiasis case. So we have 6 cases. You need to choose the top 3, and these chosen 3 top with the first part, they will go together into the final vote, the final round of voting. So we'll see who will be in the first place in the final vote. So please choose the case according to your scientific judgment, according to the scientific background, as well as the importance and the innovative part of the case. So the first case, angilymphoid hyperplasia with the eosinophilia treated with timolol and fractional laser. The second one is disseminated nocardiasis. The third one, Langerhans cell histiocytosis, mimicking genital wart. The fourth one, linear IgA bullous dermatosis triggered by brucellosis. And the fifth is erosive scalp dermatosis versus lichen planopilaris after hair transplant. And the last one, but not least, is the myiasis case. So choose your case now, and we will see who will be going to the final vote with the first 3 cases. It's interesting cases. We need to vote. Please vote on the voting system. Don't vote on the chat. Vote in the voting system. We're using the Zoom voting system, so it is in your screen. Please vote based on your scientific judgment. We don't have scientific committee to judge the cases, the top 11. We left it this time for you. Usually when we do it face-to-face, we have a scientific committee who will choose from the 30 cases in addition to your voting. But this time, because it is virtual, we decide to be only limited to the audience because we trust you and you are audience. We are very glad that you have joined us. This time we have more than 3,000 participants from all over the globe who are participating in this forum. This forum is from you and to you. We are only just facilitator, and everyone is willing to listen to your positive or even negative feedback, and we prefer to listen to your negative feedback so we can correct it in the future. So this forum is from you to you, and we are only facilitator. Please vote. So let's see how many seconds we have more left. I'm checking the system now. So we have 6 cases. The first one, angilymphoid hyperplasia, and the 6th one is the myiasis. And in between, the nocardiasis, Langerhans cell histiocytosis, linear IgA, and erosive scalp dermatosis. 30 seconds, and we will be closing the second vote, and we'll go to the final vote. So the final vote will be between the three cases, the three top cases which was chosen in the first part, with the three top cases which will be chosen from this part, and they will go into the final competition, and we will see. 15 seconds. 10, 9, 8. Okay. Now we'll see the result. Everyone is excited to see the result, and we'll see. Okay, so 362 vote for Langerhans histiocytosis mimic genital wart, followed by 263 cases for linear IgA triggered by brucellosis, and then followed by myiasis 229 case. So these are the three cases: Langerhans histiocytosis, linear IgA, and myiasis will go into the final round of voting with the other three previous cases. So thank you, everyone, and please stay tuned for the final part where we have the final, the first, second, and the third places, where they will be awarded by Saudi Society of Dermatology and Dermatological Surgery. And wait for our announcement. Just let's, maybe in 1 minute, we'll go to final vote. In 1 minute, we'll go to the final vote for this session. Please stay tuned. Don't leave, just only. So in this time till we prepare the final vote, I would like to thank everyone who attended this scientific session. The Riyadh Dermatology Forum is a forum that meets the scientific knowledge with the clinical cases. It's very interesting to see these different cases from the pediatric dermatology to the geriatric dermatology, from different therapeutics, from different procedural aspect of view. Some innovation by the new ideas about using some treatment, new modalities, sometimes linking of diagnosis. What is very interesting and very common is that a lot of our cases are very uncommon cases, and we need to start publishing it more and more. So a lot of these cases, only like handful of cases have been published in the literature. So I encourage everyone who has participating either in this chosen 11 cases or the 50 cases or more which has been submitted to us, please send it for publication. So we need to enrich the publication from our region, from either from Saudi, from the Gulf, or the Arab world, or from anywhere. We need to encourage and enrich the scientific knowledge about it. A lot of diseases are different in our region. The treatment modalities sometimes different. We have a lot of very interesting cases which are underreported. Please, my message to everyone is that keep up in reporting these cases. Don't be try to report it, and especially with in collaborating with some medical schools, some residency training programs. So reporting these interesting cases is very important, so to enrich the literature. And again, as we mentioned earlier, the Saudi Society of Dermatology will host twice a year Riyadh Dermatology Forum with the live cases, either virtually, but we hope it will be face-to-face in the Q1 of 2021. If not, we'll be virtually, inshallah. So stay tuned. Please prepare your cases. If you see interesting cases, prepare it for publication and also for submission to our forum. This forum is from you to us, and hopefully now we are finally in the final round for voting. Let me see if the voting is almost ready. And here we will see the final voting between the 3 top cases from session 1 and the 3 top cases from session 2. And you will choose the most interesting 3 cases. Some people, they criticize us. They say why they don't have expert opinion for these 11 cases. But we say that because it is virtually, maybe let the audience become the scientific judge. So now we will be ready for the final voting. Okay, they are just preparing it, the final one. It will be ready within a few seconds. So stay tuned, don't leave. And now the voting, the final voting. Choose the best or the most interesting case, either Walman disease or spotted fever rictiosis, plasma cell gingivitis stomatitis, Langerhans cell histiocytosis, myiasis, or linear IgA bullous dermatosis. Choose the most interesting case. Let's see who's the winner in the first place. Okay, we have now almost 3,000 participants. I would like to see 3,000 votes. We have to have 3,000 votes before we announce the result. Otherwise, you will stay all night long here. Okay. Still, we have time. Okay, vote for your case. You are the judge for this scientific meeting. We will have 5 minutes to vote. Take your time. Choose the most interesting case you think it's worth the first place, second place, and the third place. And just for your information, this activity is accredited for 4 CME hours by Saudi Commission for Health Subspecialties. Everyone who registered his Saudi license, it will be added to his Mumaris account automatically within the next few weeks. If you have any question, you can contact the Saudi Society of Dermatology through their communication channels. So choose your case, either the Walman disease by Dr. Amar Al-Asmari, or spotted fever rictiosis by Dr. Ahmed Nassar, or plasma cell gingivitis and stomatitis by Dr. Al-Hanouf bin Khayl, or Langerhans cell histiocytosis mimic genital wart, perianal Langerhans cell histiocytosis by Dr. Maha Fahmi, or the case myiasis by Dr. Zuhair Omar, or linear IgA bullous dermatosis triggered by brucellosis by Dr. Mona Al-Shahri. So take your time and vote. We'll see. Vote. Let me check how many minutes or seconds we have before. Technical team, how many minutes or seconds we have before you will see? 1 minute. 1 minute, and then we have the first place, second place, and the third place. Please stay tuned. Don't leave. Don't leave. Okay. So we will be ending in 5 minutes maybe, or 10 minutes maximum. So don't leave till you see who's the winner for the first place, second place, and the third place. And there is the Saudi Society is very generous in their prizes. Okay, the prizes are, okay, where's the prizes? Okay. Okay, let's see. Okay, second, count. 10, 9, 8. The final round. Please choose before you leave. Okay, let's see. If you don't vote yet, please vote. I'm expecting 3,000 vote. I'm expecting 3,000 vote. Okay. Choose between these 6 cases. Please choose. Is the time over? Let's see. Let me check. Yep, the time is over. So everyone's excited. Okay, the winner in the first place is with 384 votes for Dr. Maha Fahmi with Langerhans histiocytosis mimic genital wart. And on the second place is with 323 votes, Dr. Ahmed Nassar with spotted fever rictiosis. And in the third place is with 269 vote is Dr. Al-Hanouf bint Khayl with plasma cell gingivitis and stomatitis. Congratulations, Dr. Maha, Dr. Ahmed, Dr. Al-Hanouf, and congratulations for everyone, for all the 11 participants, for all the people who submitted the 50 cases, and for every one of you. And now I would like to invite Dr. Sami Swaidan, the chair of the Saudi Society of Dermatology and Dermatological Surgery, to present the winner of this, the fourth Saudi Forum.
He has asked me to restore.
Dr. Sami, welcome, Dr. Sami.
Thank you, Dr. Yusuf. Thank you for all the attendees and also for the organizers and the chairpersons. On behalf of the Saudi Society of Dermatology and Dermatologic Surgery, I thank everyone who participated in the success of this activity. The aim of this activity to enhance the clinical skills and also go beyond just simply lasers and dermatologic surgery. So congratulations for the winners. I think it's a great competition. It has been a tough task for the scientific committee for selecting initially between large number of excellent cases and also to go through the competition this time. I'd like to congratulate the first place winner. I think the first one is Dr. Maha.
Yes, Dr. Maha Fahmi.
Yes, Assalamu alaikum. Thank you. Highly appreciate it. It's so epic, yani. Thank you. Highly appreciated, Dr. Yusuf. Thank you. Highly appreciated.
Mabruk, Doctora. Congratulations. Good work.
Tislam ya doctor. Thank you. Thank you. Extremely thank you, yani. It was a very, very scientific presentation. Thank you. Highly appreciated. It was very informative.
We present a certificate for this. You will be mailed to you, the original one, but also we have a certificate now for the first place winner, which is your name will be there, and congratulations for the 5,000 Saudi riyals, and this will be transferred to your bank account in the coming few days. Congratulations.
Highly appreciated. Thank you, doctor. Thank you.
Thank you for
congratulations.
And thank you, Dr. Yusuf. تسلم يا دكتور. تسلم كلك ذوق. تسلم. شكرا لكم.
And now the second place is Dr. Ahmed Nassar. Dr. Ahmed with us. Dr. Ahmed.
Dr. Ahmed still with us? Dr. Ahmed?
I don't see his name. Okay. Maybe.
Okay, Dr. Ahmed Mabruk, congratulations for his case was really a very interesting and very rare presentation. So congratulations, and we'll be in touch with you. We can see his certificate anyway. He's not around, but we need to see his certificate. His name will be in the second place, and he is a winner of 4,000 Saudi riyals. and will be transferred to his account in the coming few days. Congratulations, Dr. Ahmed.
Mabruk, Dr. Ahmed, congratulations. And now the third place is Dr. Al-Hanouf bint Khayel. Dr. Al-Hanouf. Dr. Al-Hanouf.
Thank you so
I see
much.
her.
Yeah, it was my pleasure to
Dr.
be.
Dr. Hanouf معنا مبروك.
Thank you so much. It was my pleasure to be part of this, and I'm so
Congratulations, congratulations, good work. And we'll inshallah.
Congratulations, Dr. Mabruk.
Thank you so much.
We need to see her certificate too, the third place winner, Dr. Al-Hanouf. Yeah, this is your certificate where your name will be there, and that's of a total of 3,000 Saudi riyals and will be transferred to your account, inshallah, in the coming few days. Congratulations.
Mabruk, congratulations, Dr. Al-Hanouf. And now, before we conclude, we'd like to thank our strategic sponsor in the Saudi Society of Dermatology and Dermatological Surgery, the Johnson & Johnson, and they are presented here by Dr. Ula Al-Bnayan and Dr. Susan Hilal. Welcome.
Ahlan, Doctor. Thank you so much.
مبروك دكتور سوزان دكتورة ولاء. Thank you for the efforts with us here. طبعا Johnson they did a true partnership this year for 2020. They were participating in the educational activities for almost everything, for the patients related awareness campaigns and awareness in the through scientific webinars, in addition to conferences. Even they participated and support international collaboration with the ADV. And also, it's not only that, the way of the communication, it was at the professional level. And in the society, we were very happy to deal with them. And I hope there will be, the other companies will follow the same, and this nice model of cooperation between scientific societies and pharmaceutical companies. Suzanne, you'd like to say something?
Yes, Doctor. Thank you. First, on behalf of Johnson, I would like to thank you all for giving us the chance to be a partner in educating healthcare professionals across Saudi Arabia, and we will continue educating in 2021 and to support Saudi society in its awareness and educating the society. So thank you again, and it's our pleasure, and wish you all the best by the end of this year and for 2021.
Thank you for your support. Wala, would like to say something? Wala,
Thank you.
You're in close contact with her.
Yes.
Thank you, Dr. Sami. Thank you, Dr. Yusuf. Thank you, everyone at the Saudi Society. It was our pleasure to support all the scientific events and education through the society. We believe in the role of the society and educating the medical community and also the patients, and we continue to support and help the society as much as we can. And it was really a fruitful year for both of us, whether Johnson and the Saudi Society of the Dermatology, and we're very, very honored and pleasured for this. Thank you.
Thank you. And also, I think we went through a great challenge with COVID-19 because the plan of cooperation was with no COVID, challenges, but also we passed through the challenges of COVID-19. But thank you for your support. And even this event, you can see their logo. They are also part of this Riyadh Day. Thank you for your efforts and support.
Thank you, doctors.
Thank you. Thank you, doctor.
Thank you.
Thank you. Congratulations.
I need to say this one. I need Dr. Yusuf just to say one thing for the organizing and scientific committee of this conference. Also, Dr. Yusuf bin Amir, Dr. Hind Shehri, Dr. Muhammad Al Jasser. They did a marvelous work in very limited time, going through all the cases and analyzing them and doing this in a very objective matter. They were very keen to be fair as much as possible. So thank you so much. And on the behalf of the Saudi Society of Dermatology and Dermatologic Surgery, a big thank you for the attendees. I was really amazed with exceeding the capacity. We're not expecting 3,000, and also the others went to the YouTube channel of the Saudi Society. But again, we apologize if not able to accommodate everyone. But inshallah, we'll expand our capacity since there is a great, it seems there is a great, people are eager for clinical cases and challenging cases to enhance the clinical skills. So thank you for the scientific committee and for everyone who participated in this activity.
Thank you, Dr. Sami. Thank you for everyone, especially the audience and the scientific committee and the technical team and everyone behind this, behind the scene, even if we forget their names. Thank you to the audience. Thank you to the participant, either tonight or people who submitted the cases. So at the end, I would like to thank everyone. I would like to just let you know that we will, inshallah, will see you in maybe in the first quarter of 2021, and we inshallah trying to host 2 sessions of the Riyadh Dermatology Forum per year, and hopefully we can be face to face, if not maybe a virtual one. So stay tuned, and if you have any interesting cases, just try to submit it to our next forum. Thank you everyone, and good night, and have a good new year, inshallah, with the health and the safety for everyone, for you and your family. Thank you. في أمان الله. كل عام وأنتم بخير. مع السلامة.